Bismillahirrahmanirrahim. Testing on three, sound check, check 1, 2. Bismillahirrahmanirrahim. Bismillahirrahmanirrahim. Testing, sound check, check 1, 2, testing. Testing on three, sound check 1, 2. Testing. Sound check 1, 2, testing. 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 Sound check 1, 2, testing. बिस्मिल्लाहिर्रहमानिर्रहीम। ये देखें शामिर testing. Hello, testing 3 sound check. Check 1 2 नहीं testing. 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 Sound check 1 2 testing. Hello, testing on 3 sound check 1 2. गलत लगी हुई थी। Check सही check 1 2 testing. Testing on 3 sound check 1 2. Testing sound check 1 2.
इस वाले से कर ले, इससे भी कर सकते हैं।
Testing. Hello.
قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد
मुझे हाँ हाँ साफ करके डालना मुझे वो दे काश दे मुझे लगा
सही है, मैं डायरेक्ट कॉल पे चेक कर रहे हैं। वेट
हेलो चेक 1 2 टेस्ट बंद करना टेस्ट ये भी बंद कर दो ना टेस्ट उनकी ऑडियो अब आएगी यहाँ से सही है वो स्टॉप कर देना स्पीकर उसकी लेवल जो है ना 70% हेलो माइक चेक मास्टर ऑडियो लेवल सिस्टम का ऑडियो लेवल, सिस्टम का ये
और डॉक्टर्स को लगा दिए।
यहाँ से इसको 70 से
ये नहीं डॉक्टर।
70% से कम कर दो और कम कर दो। हेलो, मेरी आवाज़ आ रही है? आ रही इसी में? हेलो,
अस्सलाम वालेकुम माजिद, आवाज़ आ रही है? हेलो हेलो माजिद, कैन यू हियर मी?
वकार वर्स वे भाई दोनों।
वकार यहाँ से म्यूट तो नहीं करना है?
नहीं आप
हाँ हाँ।
आप बात करो।
हेलो,
जी हेलो।
लूप कहाँ बन रहा है? ओके माजिद, आपको आवाज़ आ रही है?
जी बिल्कुल आपकी आवाज़ क्लियर है।
बस वॉल्यूम मास्टर बढ़ाना है यार। हेलो,
जी
ये इसको मेन स्क्रीन पे डाल सकते हो साकिब भाई? मेन स्क्रीन पे डाल
उसको कर रहे हैं तो बाद में लगा लेते हैं बिना में। हाँ
जी माजिद, कैन यू हियर मी?
जी जी यस।
ओके, कैमरा टेस्ट करवाओ, कैमरा 2।
कैमरा 2 चेक करें।
कैमरा स्विच।
कैमरा स्विच हो गया। अच्छा जो भाई, ये जो इसकी लाइट्स है ना, अभी हम इसको ऑफ करा देंगे। इस समय अभी प्रोसीजर चल रहा है। देन इसके बाद ये लाइट्स ऑफ करेंगे तो स्पॉट खत्म हो जाएगा।
सही है, सही है। अच्छा, अब कैमरा स्विच करो वापस, बैक।
कैमरा स्विच करें वापस।
एको ले लेते हो बड़ी देखो यार बड़ी।
कैमरा स्विच करें जी।
अच्छा, इसके अंदर लोअर लेफ्ट विंडो जो है उसके अंदर क्या क्या दिखा रहे हो आप मुझे?
सर लोअर लेफ्ट में जो है यहाँ पर एक ईसीजी आ रही है सर, नीचे ईसीजी आ रही है और उसके ऊपर जो आ रही है ये वो है
एको
इको है।
वही सी जी सेट कर रही हैं।
अच्छा, आप दो हेड गियर लगा के कैथ लैब में चले जाओ, कैमरे के सामने आ
दो
जाओ।
हेड गियर लगा के वहाँ पर भाई एक हेड गियर आप लगा लो, एक हेड गियर अपने किसी और बंदे को लगाओ।
हाँ,
और वहाँ से 3 है ना हमारे पास? 2 हैं। एक से मैं बात कर रहा हूँ, एक आप लगाओ। एक हाँ एक अंदर लगा के। हाँ अंदर से ही बिल्कुल बात करोगे और कैमरे के सामने खड़े हो जाना। जाओ
डॉक्टर्स खड़े हैं, इनके पीछे जाके खड़े हो जाओ।
जी।
पहले आ रहे सी आए।
अच्छा ये जो अभी वो चल रहा है ना आपका
अब आ गए।
ईसीजी, इस पे अभी मशीन पे काम कर रहे हैं। अब वो अभी आ जा सेट हो जाएगी।
हेलो
जी जोए भाई।
हेलो
जी माइक 2 बात कर रहा हूँ।
जी भाई, आवाज़ आ रही है? आपको आवाज़ आ
जी
रही
मुझे
है?
आ रही है मेरे पास। जी जी मुझे आ रही है।
अच्छा,
मैं
किधर
अपने
हैं भाई
थिएटर में
साहब
ये
जो
जो
बात
माइक
कर रहे हैं?
कैमरे डॉक्टर साहब के पीछे आ जाओ जरा, अपनी शक्ल दिखा दो कैमरे के सामने आके।
कैमरे के अंदर आ जाए। ये अंदर वाला स्पीकर ऑफ है, ऑन है?
ऑन है।
जी ऑन है, अभी आ रहे हैं मेरे पास अंदर।
उनको क्या आपकी आवाज अंदर
अंदर स्पीकर ऑन है।
जोई भाई को देख के बात
सामने मैं कहाँ से आऊँगा? बंदे के बाद में बता नहीं सकता हूँ।
नहीं आ सकते हैं ये डॉक्टर साहब खड़े हैं ना, पीछे आ जाओ थोड़ा।
यार ये अपनी जा रही हो करते हैं इसकी थोड़ी सी लेवल कम कर दो।
अच्छा ठीक है।
राइट वाला बंद कर दो। ठीक है नहीं छोड़ लेफ्ट पे कनेक्शन सारा बंद है।
जी हेलो हेलो हेलो
जी
माजिद भाई।
जी जोए भाई।
जी भाई, वो अंदर करवा दो यार बंदे।
सर वो अंदर असल में प्रोसीजर चल रहा है, वो थोड़ा जाते हुए वो हो रहा है।
ट्राई कर
बाकी
लो।
वो अंदर है वैसे, लैब के अंदर ही है लड़का, पीछे खड़ा हुआ है, कैमरे के
अच्छा,
सामने
उससे
नहीं
को
आ पा
मुझसे
रहा।
बात कर ले, जो भी हैं दो हेड गियर्स।
बात करो भाई। ये
अस्सलाम वालेकुम, आपको मेरी आवाज़ आ रही है सर? ऑपरेशन थिएटर से हम।
जी आवाज़ आ रही है, लेकिन हल्की आ रही है आपकी आवाज़।
जी मेरी आवाज़ क्लियर आ रही है आपको?
जी आवाज़ आ रही है। माइक 1 है, माइक 2?
जी आपकी मुझे आ रही है।
माइक 2
ये माइक
जी आप माइक 2 बाहर से बॉस बाहर से कुछ बोल दीजिएगा
जी जोई भाई माइक 2 अब मैं हूँ।
ताकि टेस्ट हो जाए।
मेरी आवाज़ आपको क्लियर आ रही है? माइक 2 से बात कर रहा हूँ। हेलो
बॉस ऑडियो मास्टर बढ़ाइएगा, मुझे
हेलो
आवाज़ नहीं आ रही सही।
हेलो टेस्टिंग हेलो।
साकिब भाई, यार साकिब भाई इधर इसको एडजस्ट करवाएं यार, यहाँ आवाज़ नहीं आ रही। मुझे नहीं आ रही, मुझे नहीं आ रही, सामने वाले की नहीं आ रही मुझे।
हेलो हेलो हेलो
जी आवाज़ आ रही है।
हेलो टेस्ट
जी बॉस
हेलो
टेस्ट।
टेस्टिंग।
ओके
माइक देना है अभी सर को देना है? ठीक है मैं देता हूँ।
सही है। दूसरा माइक
ठीक हो गया फिर? जी दूसरा
माजिद।
माइक ये माइक 2 माजिद।
जी जी
जी
आप लोग आपस में बातें करो।
भाई माइक 2 वाले भाई, आप माइक 1 वाले भाई, आप अगर कैमरे के पीछे आ सकते हैं तो थोड़ा सा आ जाए यार।
को अफजल को पीछे जाना, डॉक्टर साहब के पीछे
खोल
खड़ा
दिया,
होकर जरा हेलो
खुला हुआ है, ये खुला हुआ है, बंद कर दूं? माजिद आप लोग आपस में बातें करते रहो।
माइक 1 जुहिब नाम है ना? जुहिब नाम है मेरा।
अफजल
अफजल भाई आप इधर आ सकते हैं?
अभी दाई नहीं किया मैं करता हूँ।
जी अफजल।
मैं इधर से अभी जाए बोले
हेलो अफजल।
अफजल को
दूसरा माइक भी ला दे।
अफजल
हाँ ओके हो गया ऑडियो।
ऑडियो डॉक्टर को बनाना है? चलो ये लो जी भाई, ये वाला माइक दे रहा हूँ डॉक्टर को, मेरा पहले वो पहनाएंगे, ठीक है? आप उनसे भी बात कर लीजिए। ये लो।
सर ये माइक लगा लो।
माजिद आपके एंड पे लूप तो नहीं बन रहा? स्पीकर का फीडबैक तो नहीं आ रहा? हेलो माजिद, हेलो।
हाँ ठीक है, कर दो जहाँ मर्जी खाओ, तो इसका मुंह इधर आए जहाँ से आवाज जाए। हाँ नहीं, मैं ग्लव्स पहने हूँ ना, इसको देखो कि मेरे इधर के करीब आ जाए।
ओके वेट,
आ जाएगी बस। सर को भी लगाना।
नहीं वो लगा रहा है।
सर आपको भी माइक आ रहा है।
असद आवाज आ रही है?
हमें आ रही है, आपको हमारी आ रही है?
बिल्कुल आ रही है, तो चलें केस स्टार्ट करें। एवरीवन इज हियर। नहीं गप लगा रहा हूँ, आई एम जोकिंग।
इस वक्त तो तुम मुश्किल से उठे होगे, तुम भी कमरे से तो नहीं जूम से?
नहीं, we can see you guys, so if you guys want to switch off the cameras, or do you want to keep them on, or what do you want? We haven't started yet though.
ठीक है, ठीक। जरा सा उस तरफ रखें, मुंह रखें ना, ये और नीचे है, बहुत ऊपर चलेंगे, थोड़ा नीचे आ।
एक्चुअली वो डायरेक्शन थोड़ी
ठीक है, देख लो थोड़ा नीचे शुरू करें सर, क्योंकि फाइब्रिकेशन नीचे ही है बस। या ठीक, ठीक।
ये सेव करना है जी। ब्लेड
देंगे है,
थैंक यू।
2 पर क्लोज खोल। ठीक है, गुड गुड। और एक 8 फ्रेंच वाली शीट भी दें। इसको ना यूं ना, इसको ये डाल के इसके फिर वो 8 का डायलेटर डालते हैं, मैं डाल
वो वायर के साथ वैसे ठीक हो जाता है।
चले ठीक है, आपको मतलब आप उसकी प्रैक्टिस है।
हाँ
ठीक कर लें, ठीक है वो
ये अब ठीक है।
पिक्चर लेंगे भाई, कॉन्ट्रास्ट दे दें थोड़ा, बाहर अंदर ही रहने दें।
जी
कॉन्ट्रास्ट है बच्चा,
डाई दे दें जी, कॉन्ट्रास्ट।
एक बंदा इधर आ जाना यार। हाँ आपने इसमें भर लिया अपने उसमें कॉन्ट्रास्ट बच्चे, उसमें 10 10 750 प्रेशर रखना है।
कॉन्ट्रास्ट प्लीज।
750 इसको ये हाँ ठीक है, चलें रेडी फॉर पिक्चर। हाँ इंजेक्ट, परफेक्ट
ठीक है।
ऊपर थोड़ा सा वो टॉर्च से तो
You need to
वैसे
test.
सीधी हुई है बस, ठीक है वायर हमने रखी है।
Asad,
सीधा
so we
करना
are
है
just
यार
doing a
इसको।
test. Can you guys hear us okay?
जी जी वी कैन
Okay, so we can hear you guys very well and see all the camera and
थैंक
everything
यू
is
थैंक
fine.
यू थैंक
रोग लाइट जी।
नादिर साहब की आवाज आ रही है सर, आप बोलेंगे
सर आप कुछ
अस्सलाम
बोलें।
वालेकुम बोल दो।
आप अली रजा, अस्सलाम वालेकुम।
Walaikum salam, sir. Yeah, we can hear you as well, so that's
चलो
good. Okay.
थैंक यू।
थैंक यू, ठीक है चलें। अरे
सर, ये थोड़ा सा
हमें
हटा यार
8
ये।
लेंथ वाली शीट चाहिए बच्चे।
संडे को जल्दी सर बड़ा क्लोज्ड ग्रुप है तो बहुत अच्छा है चले Shall we start, sir? Sir, but start kar lena. Okay. Good morning, everyone. Thank you so much for joining us early on Sunday morning as well. I'm Ali Raza. I'm an interventional cardiology consultant. I've got my fellow colleagues and friend Usman as moderating session with me as well. Chairpersons, I've got, I don't know, online, do we have Muhammad Raza, Tahir Hussain, Dr. Naeem Tahir Kheli, Asad Pathan, Bilal Murad, Abdul Hakim, Noman Nasir, Muhammad Walid, Muhammad Abdurrauf, Wasif Qureshi, Bashir Hanif, and Hikmatullah Jan Saab. So actually I can see people who are around, so I don't need to call them on stage unless you guys just come up to the stage and please come up. सामने ही बैठे हुए मेरे तो unless you guys want to sit up or down, it's up to you guys. So anyway, so I think sit here when we can Bilal, do you want, shall we sit down, because then you guys have to still talk with each other, so okay. So the first case, we will start with the case presentation first. It's a TAVR, a nightmare saved by Dr. Umar Shafaq. He's from Peshawar Institute of Cardiology. Please come on stage and present your case. Thank you.
Assalamu alaikum everyone. I'm Dr. Umar Ashfaq from Peshawar Institute of Cardiology, and today presenting a very interesting case of TAVI we did 6 months back. The title is Avoiding Catastrophe by Meticulous Pre-TAVI Evaluation, and let's dive right into the case. Okay, it's a story of a 78-year-old gentleman, known smoker, ex-smoker, diabetic, hypertensive, COPD, and a stable CKD case. He was a bit anemic. His EGFR was 45, and ECG showed sinus rhythm with the normal PR and QRS. And echo showed 50% EF, mild LVH, and his pressures, mean PG was 75, peak was 105. MDT was called, and a decision was to go with TAVI. So here's the CT assessment, and as you can see, his annulus perimetry is 90 mm with the area of 28. Very calcific tricuspid valve, and here was the problem. His left ostial height was 6.9, and STJ was also very low. It was 15, and right coronary was normal. It was 12, and here in this picture you can see the left leaflet. It was a really bulky and calcific leaflet of 17.5. and STJ is a bit overestimated here, roughly 15 mm. So there was a serious concern that it can cause coronary obstruction. So before we start with our case, here are a few different types of sinuses. In type 1, you can see that STJ is high and ostia of coronary is also high. In type 2, coronary ostia is low, STJ is high, and in type 3, both are low than our diploid valve. So in type 2B, you can see that sinus is effaced. There is not much room for the blood to fill and perfuse that coronary. And in type 3, in type 3A, you can see the STJ is wide. So blood can come into the sinus, wide sinus, and fill that coronary. In type 3B, again, it's an effaced sinus. The ostia and the STJ both are low. So again, it will be difficult for the blood to perfuse this coronary. And in type 3C, you can see STJ is narrow, though sinus is wide, but because it's a narrow STJ, again, blood cannot reach this sinus. So what do you guys think? I just showed you the CT. Which sinus resembles our patient's sinus? Anyone? 3B, sir, you have done the case, so you know that. Okay. These are the three sinus types, 2B, 3B, and 3C, we should be aware of. So this was the anatomy of sinus in our patient. These are a few other mechanisms of coronary obstruction we should be aware of. So starting with the case, both femoral bifurcation were low. We took right femoral as primary, applied two afferent proglides left, secondary axis, and right radial for our pigtail and aortograms. So here in this first picture, you can see that we took AL1, used a straight tip wire, and across the valve. It was a bit difficult crossing as it was extremely calcified. And in the second picture, you can see we decided to pre-dilate with...
sorry,
sure, sir.
Just a quick question. So why he was not a candidate for surgery? It was a high-risk anatomy, so why did you decide to proceed with TAVI instead of SAVIR?
Sir, actually his STS score was high, and the surgeons were not taking him, and it was discussed in MDT, and the patient was extremely symptomatic, multiple comorbids, so this was the only way for the patient. It was a bit risky, but still we took it on. And in the second picture, you can see predilation. We pre-dilated it with 2440. We pushed the balloon a little into the LV because we wanted to see what happens with the left coronary sinus. And there you can see, as we inflated the balloon and did an aortogram, you can see a very bulky leaflet. In the next slide, you can see that I have paused that. You can see a bulky calcific leaflet obscuring the left coronary sinus there. In this video, you can appreciate that as well. So we decided to keep the safety wire. Before keeping the safety wire, we did angiogram of the left system. It was a dominant left system. There was no significant coronary artery disease. So,
if you go back one slide, the ascending aorta looks very enlarged. What did it measure out to be?
Okay, this one, sir?
G.
Yeah.
The ascending aorta was enlarged. I mean, it's a bicuspid valve with...
Sir, it was tricuspid as I showed in the CT. But yes, you're right. Aorta is
do you
dilated.
remember what the measurement was? It looks very big.
Sorry?
4.7. I don't know. Actually, I don't remember that. It wasn't that, but this was a very frail guy, not doing anything. He used to have a puncture shop, a tire shop somewhere in a motorway, and he had no way out.
No, absolutely. I think, but I'm just saying, as a trainee, it's important to look at the aorta as well.
Aorta as well.
And
we did measure that.
Yeah, and
yes.
I might be wrong, but to me, it looked like a type 1 bicuspid.
Sir.
Could be, I don't know.
But difficult.
I have a question as well. So I think you can predict coronary obstruction. Once your coronary ostium height is less than 10, the risk is very, very high. At 6.9, and the leaflet, the VTC here is long, so you're going to obstruction. You don't really need a BAV with an aortogram to prove that. Your CT would have predicted that already. The question is, what did you go into the procedure thinking about the plans for either leaflet modification or preemptively protecting the coronary artery, because this is a left dominant system, and if you have any occlusion, the patient is not going to survive. So what was your plan going in?
Sir, what we decided, we thought that we will do the aortogram and we'll see, and we will protect the left coronary with the protection wire. And after this image, we decided to take our stent. I can show you in the next slide.
So it was coronary protection.
Yeah.
It was coronary protection. That was the plan. Not for leaflet modification, because it was very bulky leaflets and things. And to be honest, even with 6.9 and with these leaflets, I have cases where we got away with it because there's so much calcium on it that you cannot move it towards that side. And if you see the valve positioning, if you see the valve is very well towards your non-cusp. It's not moving it, but because the calcium had moved, I think with the BAV, it started moving it up, and we loosened it up, and then it started moving up. But you're very right that that was the case.
Well, I'm sure your patient did well, but for the sake of conversation, let's assume for a second this patient has not gone to the lab yet. Personally, I would, at this point in time, not just put a safety wire in, but put a guide extension catheter and a stent inside, because that leaflet will come in front of the coronary artery. There's no question about that.
True,
right?
true, sir. True.
When it does, your wire might get jailed. You may not be able to get a stent across, and the patient will not be symptomatic. If you do put a stent over there, the stent will also get obstructed because the leaflet is bulky and it's long. So that means you have to create some kind of a chimney so that it goes from the left main standing into the aorta. So you just have thinking about that ahead of time and protecting the coronary arteries actually before you even put the stent valve in, and not waiting for the valve to demonstrate that it's going to occlude the vessel before you do something. That would be my approach. But I want to say that earlier because I know I'm sure you did the right thing.
No, it's a very good approach. That's what we followed. So we did the same.
Well, just having our conversation, so it's a good thing too.
No, this is good actually. It's a good discussion because I think what Bilal is referring to is that pre-planning, because you cannot take risk on these patients, which I totally agree with. So that's what we did, guideliner and stent. So which will come up next, I think. Any other points?
Okay.
So I just want to ask, Usman and Hakeem, would they have attempted this with that significantly high anatomy and everything?
So I think Ali already said patient has no other options. Ideally, you've got aortopathy, high-risk anatomy. Then sometimes I'm not sure how it is at Taba, but our surgeons have a very low threshold of saying no. Like, oh, you can do a TAVR on him. So you really have to make that case with the surgeon. And I think yes, we are Pakistan Live, we're interventional cardiologists, but this person, the first 5 options should be surgery, 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 and then.
The reason I'm asking you, if you remember, I sent you that one of the patients anatomy also, and I think I sent it to Osman also. I have a similar case.
Yep.
Very low coronary height, sinuses small, and family were, although she was a surgical candidate, but family completely refused. They would not do anything else. And it's like.
And then I just had another question. Yes, your annulus is clearly towards 34, but your ICD and the calcium thing, I think you can get away with a 29, although you did not show us your intercommissural distance.
Sir.
Now, a 29 would be more forgiving, especially considering how big that aorta is, and you'll have a lot of space on account of that massive aorta, and you'll continue to ventilate the left system. And it'll be a lot easier or more forgiving if you were to snorkel a stent there. So I'm not sure, did you use a 29 or 34?
We used a 34.
What happened is that you're absolutely right. So this is Evolute R, it's not a Pro Plus. So I think I didn't use 29, I used 34. But the reason is this, that his geometry was so big that I thought that 29 might be loose, although I totally agree that eyes usually in bicuspids with heavy calciums, I think you can hold any valve in it. The only thing was the paravalvular leak with it, and the post-dilatation, whether I would be able to post-dilate up to the stent diameter, internal diameter of 23 of the 29 or 24 of that. So these were the only couple of points. Otherwise, I totally agree that with these bicuspids, I literally believe you can put 26 and it will be even open it up like the same way, but obviously you don't want to undersize it that much. But between 29 and 34, I agree with that. The only thought process at that time was PVL.
Okay, so thank you for the input, sir. Can we show the slides there? Okay, so we decided to keep the protection wire, and we took our guide liner on BMW and Onyx 4034. In these chimneys, you need longer stunts, so you can bring it out. So we parked our stunt in the mid LED.
So quick thing. Why don't you tell us how would you put decide on the stent size for a chimney? That has to be done before you take the valve in. Okay, so what are the considerations of doing a snorkel or a chimney? How do you decide the length of the stent, etc.?
So I take long stunts in distance from the STJ to
38.
the annulus, not 38.
46.
But depending on the left main stem size, whether you want to go into the LED, plus the distance from the left main to the STJ and how much high it's going to come above STJ. So all these things, because I don't want to run short of STJ, I want to keep it above STJ so that it crushes, there is space, because the top bit of it is going to be crushed against the aortic wall, whereas the lower bottom will remain open, and that's the part which will be pushing the stent away. That's one thing. The other thing is the tensile strength of it. So if I have probably a Megatron, I might put a Megatron in this case, or someone, some stent with a very high tensile or radial force. Any other? That was my thought, unless you want to add on anything to it.
So then we positioned our valve, did a aortogram, and then you can see we did another aortogram when the valve was halfway deployed, just before the no return point, and you can see there the leaflet is already obscuring the flow. It's just the guide liner which is preventing it from completely obscuring the flow. Okay. So we decided to deploy the valve here. In this picture you can see as we deployed the valve, there is almost zero flow in the coronaries, and the heart is barely moving. Immediately we started the CPR, and during these cardiac compressions we deployed that stunt in the chimney fashion and continued doing the cardiac compressions for almost a couple of minutes. After a couple of minutes...
Can I make a comment here? So again, see, the thing with chimney is when you're deployed 80% and you've already decided you're going to chimney, that is a time to deploy your stent. You don't wait for complete release. At 80%, you deploy your stent because you know it's a threatened coronary. The leaflet is going to be so darn bulky, you cannot pull your stent out. So you already have a stent, you've decided I'm going to chimney this. At 80%, you deploy the stent, but the important thing is to leave the balloon inside the stent, because once it's fully deployed, then you're going to expand it or sort of post-dilate it. Otherwise, now the issue is this is a self-expanding valve and you've done 2 minutes of CPR. You've compressed the darn thing. You're going to have to post-dilate this valve, and you're going to have to do a kiss with the valve and the balloon.
Yeah.
So again, with snorkel, it is very important, if you've already decided at 80%, you deploy the stent.
So we did that, but he went, and as soon as you just started releasing the valve, even without reaching 80%, he was already gone into cardiac arrest by that time. So the good thing about cardiac arrest is that you don't have to pace or do the positioning. It positions wherever you release it. So that was the good thing with it. And the other thing was that, to be honest, I think it was, we had a lot of TAVI list on that day. So this was pretty much the last case, like at 5:30 or something PM as well. So first case, this one, yeah, but the other ones, which I wish I could show you the other ones, they were really horrible as well, as bad as this. So this was the last one which I chose to do. So you're very right. These are all very good points. That's very true. And if you have to post-dilate, you have to do both kissing, post-dilatation with it.
So just a quick question. In terms of leaflet modification, is this a good candidate or not? Or what are your thoughts?
It's not going to work. There's so much calcium. There's no way on earth you can burn that. Even if you take the shortcut, you talk to your surgeons and the surgeons say it's impossible. So I've gone to the OR a few times just to see how these bicuspid raphes are. You take your sharpest needle, the biggest needle, you just cannot, it's like a pebble. You cannot cut through that pebble. It's a big chunky leaf. So basilica, all of that's not going to work here.
Sure.
Now the only thing would be if you tried unicorn.
Yeah, that's what.
If you tried unicorn and say you went through that raphe put a 5O and then a 10O and then a 20 balloon and split that. But then you would need Sentinel because that chunk of calcium is going to have to go somewhere.
Unicorn would have been good with Sapien. I think you could have done it with, you can do it with this because the concept remains the same. I've never tried it doing with the self-expandable valve, but conceptually wise, I think you can do it still because you're not going to fly it off completely into the carotids, but yeah, Unicorn would have been better.
What about sending left main first? Putting your guide liner through the stent to make sure your stent doesn't get crushed. You have some kind of an inner sort of spine to the stent, and then deploying your valve. That way your coronary is always protected.
And leave the balloon there, you mean?
And just leave the balloon there, yeah.
Okay.
Deploy the stent, keep the balloon there, advance your sort of inchworm, your guide liner, or that to protect it from stent deformation. And then deploy the valve.
The only thing is that if you have to, my thought process is that if you have to reposition your valve again, move it up and down against a deployed stent, that's my only worry there will be. But with this, probably yes.
And hence the reason to leave the guide liner inside it.
Yeah,
because then it would probably prevent.
Yes.
It's a tough situation. I'm just trying to wonder about.
But these are good thoughts actually. These are all very good thoughts. Neo 2, yes. Not with this calcium, that's the only problem.
No, actually, if you remember, we did an accurate neo. You remember that case, Usman Bhai? He'd come over, the left main was 6. So we did the same thing, we deployed, and then we ended up putting a medium-sized valve, and the left main was fine. How much of it, now the thing with accurate neo is we don't know how they behave in bicuspids. Done 1 or 2 cases of bicuspid, Usman Bhai has more experience, but I think it has to be determined how that's going to behave. So what did you do this in this? Did you post-dilate this valve? Please tell me you post-dilated that.
I didn't.
This valve is crimped. You've done 2 minutes of CPR. This thing is crimped.
No,
okay.
So what has happened is, sorry, we are live? Oh, Mohammad Raza is online.
Okay.
So I don't know, Raza, did you see the case?
Thank you so much for listening to me. Thank you.
Thank you. So I should have, on the hindsight and retrospectively, I should have done it, but the gradients were okay. The shape wasn't that good. If I had, but probably this was before, I think, IDE trial, I presume. So now I keep maintain the shape of the valve more than what I used to do previously. But yes, you are right that it should have been post-dilated, but I didn't want to take the risk that much on him because I thought that his life expectancy is less than 5 years even, to be honest.
Yeah, Raza wanted to say something.
Sure. Yes, Dr. Raza, so you are online. We couldn't see the online panels there.
They are putting it over there.
Oh, they're there, okay. So, yes, Dr. Raza. Dr. Raza is my WhatsApp mentor as well. So I send all my leaks and everything to him and he kindly replies me back as well.
It's actually other way around. You know, Ali helps, shows me some amazing cases. I mean, this is an unbelievable case. You guys hear me okay, right?
Yeah, we can hear you very well.
Yeah, this is absolutely fantastic, and the comments are spot on. It's really hard to add anything to the comments. I think I love the idea of Megatron here, so I would personally I try to do Megatron here, and then at 80%, I obviously as it was mentioned, I always check at 80% what's going on. And in this case, we knew 110% that this patient is going to need a stent. So at 80%, I deploy the stent before I release the valve, and I have more control on it, right? And I think this has already been discussed. And Unicorn, I don't think it's going to work in this case. I mean, Unicorns, to my knowledge, all are done in the bioprosthetic valve. This is native bicuspid, heavily calcified RAFE. So if you try to do Unicorn here, not sure which way the balloon is going to displace, to be honest. It could have a root rupture. So I think what you did is this was the best strategy in this case.
Sure. Thank you so much, Dr. Raza. So we have to go to the live case now. So please stay with us and then we will continue this discussion as well.
No, show us the conclusion of the case. Come on. What happened? What happened at the end?
There was this, we showed you.
Oh, okay.
You were busy discussing it.
Okay. All right. Sorry.
So he survived?
I can show you again on the, it's a live case, so let's go to the live. I can show you on this laptop again as well.
The important thing, patient survived?
So we are live here. Hello, AFIC, can you guys hear us? Asad, I can't hear you. Okay. We did do the test, it was fine earlier. Asad, can you hear us? I think they can't hear us actually as well. Okay, so sure. So we've got someone, sorry, what's your name? Dr. Hira. So Dr. Hira is here from AFIC. She's going to present the case before we go there, so okay.
Can you put on the presentation? Assalamu alaikum. On behalf of our team at AFIC, I will present a brief clinical summary before we proceed with the live case. So our patient is an 80-year-old male. He has a BMI of 18.1, and he presented to us in OPD with symptoms of dyspnea and IA grade 2 for the past 8 months. His past history was significant for smoking and hypothyroidism. His biochemical profile were normal except for low HP. His ECG was normal, and on transthoracic echocardiography, he had severe high-grade aortic stenosis with mild AR and LVEF of 60%. His CTCA showed unobstructed coronary arteries. His risk assessment was his STS scores was 1.78 and STS ACC TEVR in hospital mortality was 1.75. So our Heartwell team recommendation was TEVR. We planned for a right transfemoral TEVR with a 26 mm Evolut Pro valve. This is a summary of his pre-procedure CT measurements. The important procedural consideration for a case was that left coronary artery appears to arise from top of left coronary sinus, and there is calcium seen in aortic annulus under the left coronary cusp extended into the LVOT. This slide demonstrates the calcium. So in summary, we will be putting in a 26 mm valve with an oversizing percentage of 21%. Thank you. Let us proceed with the live case.
Thank you so much, Dr. Hira. So Asad, can you hear us there in AFIC?
Assalamu alaikum from AFIC. You guys can hear us?
Yeah, we can hear you very clear. So please go ahead.
I have Brigadier Nadir and his team with us. So first we'll let them introduce themselves and then we'll talk about it.
Very good morning from FIC Hybrid Lab. As you all know, we are going to perform a live case of TEVR. I'm Dr. Andreep Khan, TEVR case coordinator. I'm going to introduce my team. Our primary operator is Dr. Nadir Khan. The proctor of this TEVR is Dr. Asad Akbar Khan, and the second operator is Dr. Nadir Khan. We have a very helpful team of anesthesia, cardiac anesthesia, which is headed by Dr. Waqas. And we have our lab staff. There is Mumtaz Saab, Miss Nasreen hai, and we have Bilal Saab and all our team. We have a backup team of vascular surgeon, Dr. Mustansar, and cardiac surgeon, Dr. Usama. So hoping for the best, inshallah.
So you are doing this under general anesthesia or sedation?
No, conscious sedation.
Okay, thanks.
So it's conscious sedation. So the access we have two accesses. We have the right radial access for our pigtail, and we have right femoral artery access for our main sheath. So we'll just go through the pictures first. Can we show the first picture? No, beta. First picture. No, beta.
So femoral puncture किया हमने ना.
So this is a femoral puncture ultrasound guidance, and you can see the tortuosity in the iliacs. There was enough room in there, so we decided to put the sheath in. We have an 18 French center end sheath in there just to navigate that tortuosity once, and so we won't have to worry about it during the case, inshallah.
That's very good, Asad, because it's a very high bifurcation and ultrasound is very helpful in it. So no, that's very good.
Thank you. And then we, for that tortuosity, we just decided it's a live case, and we know things happen during live cases, so we didn't want to take any chance with that sort of tortuosity. So we have a sheath in. Next picture, please. So we got 2 percloses. Next picture.
So we were deciding while you guys were before case that we were using one ProGlide, one perclose, I think as well. I think Dr. Raza, what do you guys do in there with at your center? Do you use one ProGlide perclose or 2?
No, we do 2. To be honest with you, we have done 1 at times, and one ProGlide and AngioSeal at times, just for the heck of trialing it. But as a protocol, we put 2 ProGlides, which I think to me is important, because especially putting 18 French sheath, I don't think you want to deal with one ProGlide.
No, ideally I think it should be 2, but again in our case most of the time we are trying to save the cost and money. That's why we end up using 1 and then take the risk, and most of the time we get away with it.
Okay, I think Abdul Hakim uses regularly 1, isn't it? Abdul Hakim, you use 1?
Yeah, I think we switched over to 1 a while back. We've done well over 90 cases, and I can't. I'll tell you, if you have, say, a persistent ooze, you can take a 7-8 balloon, leave it up for a good 3-4 minutes. We've not had to repair a single groin surgically.
Sure. Okay. Yes, Asad.
Okay, perfect. So this is us. We usually take a dry cine before we cross the valve in a LAO view. Just it shows us obviously degree of calcification, but that we have seen on the CT scan already, but also it shows us where to aim for. So you can and see the orifice very nicely. That's what we were aiming for. Next picture, please. So next picture. So that was just us crossing, and then once we have crossed, we always go into the RAO view to push our wire towards the apex. And then once we have pushed the wire in the apex, this was very tight, so it required a bit of struggling, but we constantly kept the tip of the wire in view and made sure that wasn't really hurting the apex much, because even in hypertrophied ventricles, that's usually the most tricky spot. So that's a next picture, please. So now we have this is our AL1 catheter, and then when we are pushing the wire, we make sure we don't really push the wire out of the tip. We would typically unsheath the wire tip, and then it comes out in a nice loopy fashion. And then after that, we have put a pigtail in. Next picture, please. Next picture, please. So, so this is where we are right now. Normally, we would never put a stiff wire in while we are waiting for the valve to be prepared. We normally ask the valve to be prepared once we have access, and once we have the access, we would normally put a benign sort of a catheter like a pigtail in the LV lumen, and then we start prepping. So the valve is ready. We have not checked it yet because it just got ready while we were talking to you. So we'll check it live in front of you guys.
Asad, it's Usman. So a quick comment. What we've been doing since day 1 is at this point we do a second checklist, kind of pause and go through all the roles of everyone in the team, you know, who's running the pacemaker and the shock pads, and we make sure we have all the equipment in the room. And the second thing is it does look kind of horizontal, at least on the angio. What was the angle?
Even on the CT, it's a bit horizontal. So hopefully, we will have to probably do a few maneuvers to get the best position that we can.
So you're planning to pre-dilate or not?
Yes, we are. So the minimum diameter here is around 18.6. So we are going to pre-dilate with an 18. अच्छा जी जब सिने करेंगे तो okay, start सिने.
So, Dr. Raza, do you pre-dilate all your valves, or do you have a selection criteria or anything for it?
You know, it's very interesting. At this point, we pre-dilate every valve before evolute. In the very beginning, we didn't actually. So we learned in a hard way that it's better to pre-dilate. It helps in many different ways. The valve deploys better, it expands better, and then it decreases the chance that you have to post-dilate. So I think at this point, we pre-dilate everything.
Yeah. Sure. And also it gives you the time that you need in the aortic orifice. You are not occluding it. So it's when you are placing it. So especially if you're looking for very high deployment or something. You can take your time because there is a bit of flow around that catheter of yours. So I think that provides you stability as well.
What does everyone think about?
The only thing with BAV is that as you are well prepared, right? So your valve is ready to go. I mean, it's kind of a common sense, but you have to make sure valve is ready when you do BAV.
Yes, exactly.
If there's AI,
100%.
then you have to move on.
100%.
That's true.
So if we want to go through this picture, we have this cine running. So you can see the handles very nicely. We usually start from the 3 o'clock position. Some people would do just one quick cine at 3 o'clock and then at 9 o'clock, but we would usually do the whole 360 degrees. You're looking for the handles which look perfect. There's no problem with any of the valve stuff, and we don't really have, there is a bit of constraint towards the tip, but that's up till the third node. So I think that's safe, and we are using a Pro Plus, so that's probably the external skirt. So I think that's a perfect prep.
And pacing wire, everyone does pacing wire or over the wire pacing?
I've moved over to a pacing, LV wire pacing exclusively for the last 3 years. And I think it just works beautifully. You save money. There's less risk of complication with the transvenous pacemaker. You can actually pace through it even if the patient needs long-term pacing. And we can just pace it and then have our EP docs come in and they can put a preliminary wire in from the subclavian vein and observe for the next 24 hours. Because many times these heart blocks actually do resolve also. So yeah, I haven't put in a temporary pacemaker in 3 or 4 years.
Sure. We are doing the same.
You're doing the same as well.
Yeah.
It's only because Sapiens initially during my training times we were doing LV pacing for the self-expandable, but for Sapiens we used to do TPM. But now, since that was 2-3 years ago, now people have moved on for Sapiens as well with the over-the-wire pacing.
I think not everybody has moved on. A lot of people still do this pacing because it sort of gives you that stability. We were talking about it yesterday, and I think Usman does proper pacing as well. We do the same, and I think for me, any PVC during valve deployment, I understand that people have very good experiences with it, but then you always hear about that one case where that PVC happened at the last minute and the valve popped out. So we feel comfortable putting these wires, and we haven't had an RV perf or anything like that with these wires. As long as you are safe enough, I think these are pretty reasonable. We can always take them out. For all valve-in-valve cases, we have been doing over-the-wire pacing because there you are almost sure it won't need anything afterwards. But for most of our cases, we are sticking to RV pacing.
Sure. Usman, I know that you do a lot of accurate NEO2. With accurate NEO2, the pacing demand is not that much. What do you do with those ones?
So I generally like to have good control of everything, so we use a temporary pacing wire. And whether it's Evolute or AN2, we put in a pacer in the...
Sure. So you guys go ahead, Asad, and continue with your procedure.
Let's go RAO view, please. So what we are going to do is we're going to put a stiff Confida pre-shaped wire in. Yes. So as Usman said, very rightly, we went through the roles while we were waiting for you guys. Dr. Nadir will be the first operator. We have a person on the pacemaker, we have a person on echo, and we have our anesthesia team ready. We have our pads ready for shock.
What was the gradient across the valve? Did you guys check that?
It's around 70. 70. We measured it. It's around 70. I think on echo it's a bit even more, but obviously what we get here is not really exactly what we see as peak on echo.
Dr. Raza, if you're doing even do you use Confida, Safari, or any other wire or any wire of choices?
Mostly, I'm more of a Confida fan.
खामोशी चाहिए रूम में और एक बंदा पेशेंट क्या करे. Sir, please continue.
So the pacer wire, is it balloon tipped or the regular one?
It's a regular one.
Yeah, we have seen quite a bit of complication. Now we have moved to, if we have to, we really use the balloon tipped one.
Sir, they are very expensive and then very hard to get actually.
Any consideration to using Lendequist because of the tortuosity and it's a little horizontal to get more pushability?
Bus.
So,
Pacer ready?
No one had a, actually that's a very good concept he was trying to, you guys go ahead and do your balloon. So about LenderQuest wire, so any any ideas about that for horizontal aortas? Dr. Raza, what do you think?
Yeah, so I mean that's the traditional thinking, and I think is a good one. With the FX and Proplex, it actually deploys pretty coaxially. So I don't think we need Lundy as often as we used to in the prior system. As you guys know, that FX has one spine versus the Evolute had the previous version had two spines. So it is not, to me, it's not as important as it used to be.
Sure. And Asad, the General Sumor Saab was here, so he thinks he will provide the balloon tip. Why are you talking about money in FIC? You already have it, okay. See, they don't give it to other people.
Madam, French or
Asad, what was the balloon size there?
18.
And,
so the
and
minimum
the
diameter was 18.6. So we went with an 18.
It looks like a short length balloon. Is it? It's 18
by. Yes, 18 by 40.
Asad, the calcium is bulky. I'd recommend you go with at least a 22 balloon here. You don't want to be post-dilated.
22, actually the perimeter derived area is 20. So that will be very aggressive. Huh? So we might do a post-dill here if we have to.
Dr. Bilal, what do you think about pre-dilatation with the, what's your sizing?
I think that will be very aggressive, Hakeem.
So generally, I predominantly use the sapien valve, and I think you don't really need to do it unless it's a bicuspid valve. You just do basically enough to be able to create a space so you're not struggling. I think pre-dilatation is more important for the balloon. It's a self-expandable valve. Because the radial strength with the sapien is more, post-dilatation needs are very rare. If you don't adequately pre-dilate using a self-expandable valve, then you end up with more post-dilatation and more leaks. So I tend to use the 16 to 18 valve. It's smaller because I'm predominantly a sapien user.
Sure. Dr. Raza, what do you use for sizing pre-dilatation?
Yeah, so I agree with Bilal, but for sapien, you almost never need it. We got stuck 2 weeks ago where one of my partners couldn't get a sapien across the valve, so we had to do some maneuvers to get in. But I say this happens maybe 1 in 5 years. So in general, for sapien, we never do pre-dilatation unless it's critical. The gradient is like 80 and the calcium score like 7,000 or something like that. Then we would do the pre-dilatation for sapiens. For the evolutes, I think you have to go by several metrics, and I think Asad is doing a great job with going with the perimeter derived. That's just one way of doing it. You have to make sure you're safe with all the calcification and LVOT calcification. So you could go with either with the mean or you go with the minimum. So it depends on how much calcium is there. If there's a lot of calcium, you want to modify. I think you go a little more aggressive, as I think I think probably Abdul Hakim was suggesting. But it's, I think, either 18 or 20. I think it's okay.
Sure. So I've changed my. Sorry. Yes.
In a horizontal route with that degree of calcium, I agree with Hakim. I might have considered doing another pre-dill with a larger balloon.
So I've changed my practice. I go perimeter derived -1. Even for this, that's mainly after IDE trails and things, because I used to do minimum diameter. Yeah, so perimeter derived was 20, is it?
No, I think, I think at the end of the day, you've got to ask yourself 2 questions. You're going to put a 26 valve, okay, so you can easily put in 22, 23. Well, if you don't have an hostile STJ, you don't have LVOT calcium, I think you can get away with pre-dilating with a 22. I mean, those would be 2 fundamentals you don't want to ignore. You are putting a 26 valve.
How can you call it a fundamental thing when it's totally never recommended anywhere? You go above. How can you go above perimeter derived? You can go as equal to perimeter derived, but where is it in the fundamentals that you go above the perimeter derived diameter?
Asad Bhai, you're putting a 26 valve. The
So in
diameter
the
of a
diameter
26
26
valve
is
is going to be
22.
22 to 23.
No, it's just 22.
The area that you're really going to achieve with a metallic ring is going to be 22, 23. So my point is that yes, that's what the textbook says, that's what we're taught. But
that's a
you see
fundamental.
over time. Now let's just say this valve is under expanded. Are you going to post dilate it with a 18, the 20
No,
or a
we'll
22?
pose it the 22.
Exactly. So that's my
Or a
point.
20.
You're going to use a
Ah,
22
nahin,
at the end.
Lekin, Hakeem, my plan is right now, the plan is the balloon that we have on the table is 20. So perimeter derived area is 20 and that's what we will go first. If need be, we'll go more aggressive. But
Yeah.
I think safety is within those numbers.
Okay.
Yeah, I agree with that. I think, Asad, this is a great game plan. Although I understand what Hakeem's argument or debate is,
So-
I think either way, I think it's going to work fine.
Go ahead, Asad.
Perfect. So I just want to show one thing. So we end up for commissioner alignment. Fluoro mein hai, sir? So for commissioner alignment, we went in with the flush port at 3 o'clock. But because we saw all that tortuosity in the iliacs, what we have been doing is before we turn around the aorta, we check for the position of the hat marker in this position as well. And if you look at it, it's already in the inner curve. So it's very high likelihood that this is not going to be right for commercial alignment. So at this point, we are in the descending aorta, so we can actually turn on under fluoro guidance and get our hat marker towards the outer curve.
So Asad, you have got 15 minutes, so go ahead. I think usually sometimes it aligns itself as
so
well.
This is
it
our
goes
hat
up
marker
on
at
the
the outer
aorta.
curve. We'll cross the aorta. Chale, follow kare back.
Sure.
How many
हाँ,
of
ठीक है, we'll
you,
start deploying
I mean, this
first.
is not horizontal enough, but how many of you would consider a snare in advance while making the valve go through, so you're prepared for it, in terms of planning for this horizontal
बच्चे आ रहे
route?
हो कॉर्डल?
बस ओवरलैप में आ जाएंगे.
I mean, we always have the equipment available, and if it's a really horizontal route, if we need to, then it's
अब हम picture
it's
लेंगे. बच्चे
available.
fluoro वाला
But,
बंदा
you know,
वाला मेरा बात
we
सुनो.
try to do our best. I haven't
और
had to
प्रेशर
do
वाला
it
भी
ever.
बात
It's always cross. A couple of times we've had to do balloon-assisted crossing with the second wire and a kind of a buddy balloon to help facilitate the device to get
हम
across.
शुरू करते हैं. अब करें. सिने करेंगे.
So Asad has crossed
Inject.
nicely.
Perfect. So we are in this view, we're just confirming and making sure that the pigtail in the non-coordinate cusp is at the bottom. So now we're gonna, and the hat marker is the band is right in the middle of the pigtail. So we're gonna start deploying. So we typically start pacing from the start. So pace 120 just to avoid any PVCs and just sort of gives us that added stability. Chale. Fluoro ko wire. So one node is out, the second node is out, and this is the third node out. So here we'll take a quick picture. Cine, inject. It looks a bit high, so I'm gonna.
I think it will.
just partial
You're good actually. It might be okay.
Partial. Okay,
It will go
yeah.
down.
Okay, we'll take a quick picture again. Inject. This looks better. So from the third node onwards, we go a bit rapidly up to the point of no return. Here you can see the rumble. So we'll still keep going until we see barely any whisker between the marker band and the top here. We're going to stop here. We'll check the pressures. So we have the pressure right now is 98 by 60. So we are good, stable hemodynamically. We'll check, take a bit of parallax out. एक मिनट रुकेंगे, फ्लूरो करें सर. थोड़ा सा कॉर्डल और करें हल्का सा. कॉर्डल बच्चे.
So while you're doing
Guys,
that, there's a lot of tension obviously on the valve. It's a horizontal
Yes, we'll
route. The
take that
valve
out.
is more vertical. Plus,
Picture लेंगे next.
you can see that it appears that the delivery system is hugging kind of the inner curvature.
Perfect. Yeah. थोड़ा सा आगे. ठीक है. LAO में आएंगे. So we are good on the non-conicus. We are going to check the position in the left. I took that point well. अच्छा, इसमें थोड़ा सा कॉर्डल की तरफ आए.
So this is really important to make sure you always check in the LAO view.
We'll take a picture again. So, cine, inject. So what do you guys think? I think we are pretty good on the non and the left.
I think it looks great. I just want to, I think at some point we can pull the wire back into the nose
Yes,
cone.
we'll do all that in the third part. So we're taking the pigtail out. So forward pressure rakhenge front. So front operator at this point is going to keep a forward pressure. The third operator will pull the wire back a bit. We typically would take the black part into the nose cone, get it away from the LV. And this part is really, really slow. So we do really we really do one cone at a time.
Yeah, because there's a lot of torque in the system.
So we wait for the head marker to come out. Perfect. Okay. So there it's come out. So we're going to pull the thing.
And you can tell there was a lot of torque in the system because the way the nose cone kind of jumped into the valve on deployment.
Okay, sir. एक मिनट आप उसी उसको पकड़ेंगे. Okay. So we're good here. So we'll do our echo assessment. In the meantime, we'll get the valve out. Get a pigtail, please. Fluoro stop कर लेंगे. ठीक है. Pacing off. Okay, so this valve we know keeps expanding for about 8 to 10 minutes. So we don't do our angiograms until that time, and we do echo measurements, and we usually get a pigtail in just to make everything stable while we're doing all this.
So do you always remove your pigtail?
Yeah, I know people don't, but we would, unless it's a tricky one, we would typically, once we have confirmed the position in a RAO view and the LAO view, I think there is little role to leave it there.
No, I agree. Some people do and some don't. So either way, I think it's fine.
So Raza, what's the advantage of leaving the pigtail there?
As a marker, Bashir bhai, like if you don't have very calcified valve, like we are participating in Expand 2 trial, where the calcium score may be like 400 or 500.
20 balloon.
So you want to have some marker to make sure when you're deploying, it's not moving or something. It's just for more confidence purposes. But if you have calcium like in this valve, you exactly know, and A, it's not going to move. B, you have a lot of markers there to make sure that you know where the valve is.
Okay.
Yeah, if I'm doing it for aortic regurgitation, I sometimes leave it usually, but for AS, sometimes I remove it as well.
So I always leave it in because I don't want an extra step around the time of valve deployment. So with all the valves, I just leave it there and then carefully take it out over wire.
I guess the only reason you want to leave it in is mostly as a marker, right? There is really no function for that.
So, Hakeem, this is our RAO view. Huh? What do you think?
I think your valve looks really, really nicely expanded. I would do two things here. I would go RAO Cardo, and
this is RAO Cardo.
This is RAO Cardo. So it looks really nicely expanded. Now the other thing I'd like you to do is go extreme RAO cranial, and you'll actually look at the outflow of the valve as a circle. So try going extreme RAO cranial.
If it is so good, do you still go RAO cranial?
Just as a demonstration, live case.
So can you go RAO cranial, please?
Go extreme RAO cranial, and you'll actually look at the outflow of the valve. And if it's perfect circle, you don't need to do anything, okay? But if it looks elliptical, trapezoid, then but here, RAO Cardo looks perfect. You've got a beautiful result. Very nicely done.
If you do a TE on him, it's going to be elliptical because the self-expanding valve is going to conform to the annulus, right? That's the beauty of this valve. But it's well expanded given the anatomy. I think I personally agree with everybody. I wouldn't do anything else as far as there's no PVL.
Yeah. So now because we were discussing this earlier as well, how many of you guys will try to make structurally this valve okay as well if there is no gradient?
So there's no gradient, there's no PVL.
There's no gradient, no PVL.
Well, see, the thing is, this is supraannular, right? If supraannular, it doesn't matter what the shape of the LVO, unless there's obvious constriction over there. If you have got no gradient, you have no PVL, don't do anything.
But so was AN2 in IDE trial. But it didn't come out good.
That's a separate debate. You know.
But I think since the IDE trial, I'm much more cognizant of a constrained valve at the annulus, even though these valves are supraannulus, that if it's visibly constrained, you have no PVL, no gradient, but if it's visibly constrained, I might, I think my threshold is lower now for post.
What about you, Piram?
So, you know, if you talk with the Boston folks, they'll tell you that in the United States, the new accurate valve has been withdrawn. And when they say that they didn't learn from their European counterparts, who kept telling them that even if you get a good gradient, post-dilate that valve. And so in the immediate post-procedural gradient might be okay, but if it's a self-expandable valve and you have a calcified root, or you know the anatomy is hostile or whatever, go ahead and post-dilate that. So I don't have enough experience to make a comment like you know the other guys do, but I do think that if it visibly doesn't look right, I think it's even if the gradients are okay, as long as you're not so high that you may have a valve embolization, I think it's reasonable to go ahead and post-dilate that.
See, I think we actually have seen quite a few now. I've got a patient, and I discussed it with Usman Bhai. The guy got an Evolute R in 2019, 34 millimeters. He now has wide open AI. I have done a core valve and a core valve, and I know Usman Bhai has done a core valve and a core valve. So I think this is problematic because transcatheter valves are now 10 years old in Pakistan, and we've started seeing a lot of these fail. So I think we should optimize the valve as much as we possibly can. The question is, if the valve is fully expanded, you do not have PVL, I think you're great, but this is your opportunity to optimize it, because if this thing fails, you have very few options left.
Sure. I said we just want on the demand of the house here. Can you just show us an RAO cranial if you've got time, and you've got like 4 minutes remaining? So
yes, we can go RAO cranial. Yeah, we did a few images, echo as well. It looked pretty good, so we took the wire and stuff, and we'll go RAO cranial to show you for any.
Abdul Hakim wants to see this valve from top. You have to fulfill his
no,
wishes.
please. I said this is all Ali Raza, okay? I just mentioned that this guy is a troublemaker, okay? Go RAO cranial.
Off DSA, 1 minute. We are on DSA, we were getting ready for peripheral.
Yeah, look at that, how circular it is, Abdul Hakim. Happy now?
See, the thing is, if you're immune to... No, go more cranial. I'll tell you why this is relevant. We do a lot of bicuspids.
Yeah,
okay?
that's true.
We do a lot of bicuspids, and your echo probably is not going to show you. But if you make this a habit and go extreme RAO cranial, trust me, one of these days you'll call me and thank me.
I agree. I go actually RAO cranial. I'm just saying.
So look at that. See, that is such a beautiful demonstration. Keep going more until you see a perfect circle. Keep going more, keep going more, keep going more.
This is the Hakim. We are on RAO 37, crani 50.
Now, yeah, your machine is stitching RIC now, so that's it.
Thoda modify kar le, but you get my concept, right? You see how nice and circular it is.
That's a great concept, yes.
Good job.
Yeah. No, that's a good view.
Okay, thank you so much. So I think you guys did an excellent job. A big round of applause for the team at AFIC. Very well done. Thank you, Asad. Thank you so much. So
thank you, Ali,
and beautifully done, Asad. Excellent.
Thank you. It's the team, like the AFIC team is probably the most probably senior in terms of time that they have been doing it. I think they did the first one in 2015, mashallah, in Pakistan. So I know NICFD has done more numbers, but there is more years on this side.
Yeah, and boss is here as well. So boss was here, so that's okay. Thank you so much.
And money as well.
Okay, so we are going to go to our next live case, which is going to be RIC soon. So I think, is there anyone for Mustafa is here from RIC to present the case? Is that correct? Okay, so go ahead, Mustafa, please. Usman.
Inky slides lगा दें, please. The mic is not. Can you turn the mic on?
And today we are going to present a live case of TEVI from Rawalpindi Institute of Cardiology. Next slide, please. The operators on the case are going to be Dr. Asem Javed, Dr. Abdul Salam Azad, and Dr. Adilur Rahman. Can we see the next slide, please? So the case summary of the patient which is being performed today, the case of TEVI, it's a 74-year-old female. She is diabetic, hypertensive. She had her PCI to circumflex done in 2022. The presenting complaints are dyspnea NYHA class 3. Her lab work is normal and the frailty score is 4. So,
just if you could pause there for a second.
Sorry.
So, just to the panel, are you doing routine angiograms in all the patients, or just using the TAVI CT to look at the coronaries, or angiogram at the time of the TAVR?
CT, predominantly CT. The default is CT unless CT shows something of concern or can look at the coronary because of calcification. And sometimes we'll do it at the time of the TAVR as well.
Yeah. See, in this patient, because there's a history of stenting in the past, this is one patient I would just do an angiogram, although you're using an accurate neo, so, you know, reaccessing the coronaries shouldn't technically be an issue.
Okay.
Raza, what are you doing? Because yesterday when we were talking to the US colleagues and some of them were doing routinely and others were saying they don't do it. What is your practice? I think he's gone, probably. So I think what we do is also the same thing. Like if there's nothing on CT, then we won't. If we see a lot of calcium, we are not sure, then we'll do it just before the TAVI.
Yeah. Go ahead,
Okay. So the echo shows severe aortic stenosis. There is mild to moderate calcification on the valve, and it's a tri-leaflet valve. The gradients are around, the MPG is 39.5. and the aortic valve area is 0.7 centimeters square. Her ejection fraction is 60%. So after the MDT meeting and the STS score calculated on the patient, it has been decided that she's going to undergo a TEVI. The valve we're going to use is Accurate New 2 from Boston. And here are the CT analysis of the patients, which shows the aortic annulus perimeter of 71.2 millimeters and the perimeter derived area of 22.7 millimeters. As we can see, the heights of the coronaries are good, so we'll be comfortable on that part. The left coronary artery is 21.6 millimeters and the RCA is 14.6 millimeters. The AV angle is 43 degrees. So based on this CT analysis, we're going to use a medium-sized valve, which is a 25 millimeters valve, and
so
also,
if you could go back,
just a quick thing. Can you go to the previous slide?
Yeah, could you go back one slide?
See, the valve is widely opened here. Look at the bottom right picture. Have you perimetered that valve? Because it looks to me, your gradient's 39, and you can actually see a nice healthy orifice there. Now maybe the cut is much higher or much lower than the most constrained part, but here I would question if this indeed is severe AS.
And then the degree of calcium is also not tremendous. So when you have gradients that are borderline, you don't have a ton of calcium, and you see that, you know, in a systolic phase the valve is opening, you do have to kind of make sure you reassess the valve and it's fully severe. Reasons why you could have elevated velocities through the valve, you know, check for anemia, check how much AR there is, because that's going to, and check your LVOT velocities, because that can confound your assessment of the aortic valve.
And you can actually see a fairly healthy, thick stake of muscle right there. So the question is, how much of this is LVOD gradient from a hyperdynamic LV? So just a very important point. Not every high gradient across the aortic valve is AS.
Yeah, that's right.
Okay.
So it's been, the patient has been properly, the gradients have been checked, and the aortic valve area on this patient has been calculated, which is significant, comes out to be in the category of severe aortic stenosis. So we're proceeding with TEVI in this case.
The other thing you can do is do a valve calcium score, which is very helpful.
So because there's a lot of fibrotic elements sometimes in the valves, although I understand the CT scan and which Mustafa was showing there, but I think because they must have gone a very thorough assessment before it, and I'm sure they would have decided it's a low valve area to proceed with it. So I think, yeah, Mustafa, go ahead.
Sir,
and at a perimeter at 71 is between a small and medium valve, so going with the medium-sized valve and oversizing is the right thing to do.
Sir, so the vascular anatomy of this patient is also favorable. There's no significant tortuosity, and the vessel diameters for the excess are they are good. So we're very comfortable on that part. There's very less slight calcium in the lower abdominal aorta. Other than that, we don't see any challenge there. So that's the case summary. So now we're going to go live.
Can you go back to that first CT review, because I think the question of pre-dill comes up again. So one more. So right there, so your perimeter is 71 and your perimeter derived diameter is 21. And so with open to the panel like Abdul Hakim and Ali Raza, what would you pre-dilate with over here for a, sorry? It's 22.7.
22, it's perimeter derived, so accurate neo2 says -1, so you have to do what accurate neo2 says to you. And if you're doing their IFU actually now says perimeter derived -1, so it has to be 21 something in range.
No, it's 22.7, so I think 22 is reasonable.
Yeah, 22 is okay as well, but I don't want to stretch this valve too much because there's not that much calcium in it. So I would say I might go around with 20 something, 21. That will be okay as well for the valve to open, I think.
But you know, with the accurate neo2, they want to be a little bit more aggressive with pre-dilatation as compared to others, because that's what they're blaming everything to.
Very true. So the perimeter derived -1 is their formula. So that's
right.
So you can even do 22 there. It won't make any difference.
22.
I agree.
So there isn't a lot of annular calcification or STJ calcium. So with aggressive pre-dilation, the only risk you're running is AI. So important having the valve ready to go when you do the pre-dill.
That's right.
So let's go to the live case, please.
Thank you very much.
So Raza, what are your thoughts in terms of, and first of all, have you had experience with the Accurate platform at all, and then thoughts about pre-dilation of the valve for Accurate Neo2 versus the other platforms?
So we were part of the trial. We did 2 cases a while back, and to be honest with you, nobody's talking about Accurate Neo in the US anymore, to my knowledge. We kind of signed off on this based on the trial. So there's not much discussion at all, but I do agree with the perimeter drive -1 is reasonable.
So we're just waiting. I think we're still seeing the AFIC. So, Accurate Neo or Neo Prime is still FDA approved and available in the US. So, are people using it, not using it, or is the IDE trial?
It's not commercially available. It was after the trial. I don't think anybody has used it since the trial, to be honest. In last TCT, you guys remember. So it never got into commercial space. So, I mean, in the in the continuous access protocol, people could use it, but after that data that came out of by Mike Riordan, I think the data was so clear that everybody walked away from it.
You guys are still using it, Usman. Can you explain after that trial what was the issue and why do you believe in it and why you're still using it? If you had an option in this case to use Medtronic as well, why would you go for it?
Yeah, so I think it's an interesting thing. So if you look at the trial design, it was the average operator experience with the valve was less than 5 cases. The average pre-dill balloon used was 18 millimeters. Whereas, the European experience has said otherwise, that the Europeans have been pre-dilating more aggressively with accurate Neo2. So I think it's interesting. It's they also did the trial during COVID, so operator experience wasn't that much. So yeah, I think it's for us having a valve that has low pacemaker rates and good post-TAVR coronary access is important. And so I think unless
that might be solved with the FX version now. They have a bigger, for the coronary access and for even commission alignment is much better with the dots at the end. So I guess, but the main issue was just the post dilatation would solve the problem. You think with the?
I think it's going to be interesting to see long-term results from all of the cases that we're doing. And seeing what the patients are, how the patients are. We haven't, at least in the short-term follow-up of 6 to 12 months, we haven't noticed any issues with the valves.
A quick question.
That's a great point, Numan Bhai, that one of the biggest criticism was, as Usman mentioned, is the operator experience and post-dilatation and whatnot. But the data is data, and if accurate Neo has a life in this space, they have to prove with some trial that it is a safer and it has a good durability. Otherwise, I think in the US it's not going to work. And based on the information I have, actually, they didn't even want to present this, to be honest. Boston didn't want to present the data, and they didn't want to publish it. But then there was a lot of criticism from a lot of the PIs from different sites that no, you got to publish this. You can't hide it.
Yeah. So I think we are on. We're seeing RIC. So RIC, Assalamu alaikum. You're on the screen here. We can see your screen. Can you guys introduce us to yourselves and tell us about the case and where you are? Asim, can you hear us?
Usman, can you hear me?
We can hear you really well, Asim, and we can see your
wonderful.
screen.
So welcome back to RIC, and today we want to perform this TAVI valve, which is Boston Scientific. So with me, I'm being assisted by Dr. Abdul Salam and Dr. Adil, and our expert is Dr. Waleed. So what we've done, I think you've got a case presentation there. Dr. Mujtaba is in the hall. So
we had the case presentation, yes. So we reviewed the patient data and the CT scan.
Okay. All right, wonderful. So I think I'll let Waleed take over from here, and I'll keep doing the work.
Excellent. Good morning, everybody, and welcome to this live case. So Usman, on the basis of CT, what do you guys think? What size of valve which we should be using? And what size of balloon should we use for our pre-dilatation? Was there any discussion around it?
So we did have that discussion, and Abdul Hakim, what do you think?
Wrong question.
But I'm impressed at the amount of calcium we're seeing on fluoro. The CT suggested that there wasn't a lot of calcium, but on fluoro, it's reassuring.
What's the calcium score of this valve? Was that calculated? How much calcium there is in the...
So Abdul Hakim, it was around 500. And if you kind of go to the hockey stick wheel, you can see the calcification over there.
Okay.
On the leaflet notes. Can you hear me, Abdul Hakim?
Yes, loud and clear. Okay, so the calcium score is 500. You've got a mean gradient of 39. And I think it's a borderline between a small and a medium. I think there were two schools of thought. One, because there is not significant calcium, a 20 should be fine. If you just go by what the IFU says, then a 21.7, i.e. a 22 should be good enough to pre-dilate.
Excellent. Yes, that's what were our initial thoughts as well. But if you look into the CT measurements of the LVOT, so the LVOT is around 21 point something. So we don't want to go too aggressive and just only follow the IFU in terms of to do perimeter derived diameter -1. So we have downsized our balloon to 20 due to these reasons, the LVOT measurements. Due to not much calcium, and so we'll be using 20 millimeter balloon for our pre-dilatation.
So, Walid, can you show us a cine of the dry cine of the valve? Can you show us that?
The accurate NEO2 sizing, in which the lower limits for the perimeter derived diameters has been dropped down by 0.5. So it's kind of falling in the lower range of the medium, and that's what we have chosen to go for, medium accurate NEO.
Also, depending on which balloon you're using, like the
dilatation, which we will decide towards the end of the case, then we will be using a 24 millimeter balloon.
So Ali Raza, can I just ask you a very naive question? I haven't done TAVIs for a few years now. But when we used to do these, what is the significance of calcium? We got about 40-50% of tricuspid, a lot of calcium initially. So now has it changed? I mean, the calcium, is it the expandability of the valve? Why do you take the calcium score in? So you used to look at the anatomy, the perimeter, and all that sort of bicuspid. So what has the calcium score got to do with it?
Sir, the main reason he asked for is because it was a bit of a openish valve with a doubtful type of a severity. So the ESC says that if your calcium score is like 1500 and above, then you can diagnose it with severe aortic stenosis. That's the main reason of it. But you're exactly right that for you, the other parameters which you mentioned are the most important one than the calcium ones.
Does the pre-dilatation versus no pre-dilatation, does it take into account? Because
so very, I will let other chip in as well, but very heavily calcified, like Dr. Raza mentioned, that those ones who have got a calcium score of like 4,000, 5,000, you think that logically these valves will be difficult to open up, so then pre-dilatation on that. But the pre-dilatation they are mentioning is basically to maintain the valve, because this valve is not that much of a tensile or radial force. So they want to keep the structure of the valve very well circular, so that's why they are mentioning all this.
So the balloons that we have available, at least at AKU, are very compliant balloons. So if you take a 20, I think it's a Polish company, and really go hard, it goes up to around 21.5 or 21.7. So sometimes we use that inflation to kind of use the same balloon to 20 to a little more aggressive.
I think one of the things you can also use the calcium score is to try and understand some of the stroke risk as well. So, you know, especially in younger patients with high calcium scores, I think using a sentinel device or some kind of cerebral embolic protection system helps. The data is not very strong on that, that's why it's not routine use, but I think if your calcium score is 4,000, 5,000 or above, then as you know, the risk of both an annular rupture and stroke both increase. So I think it does help us to risk stratify the patient.
So my understanding for this, that we could not, from all the trials, we couldn't find out any high predictors for the stroke. Yeah. Even the calcium score wasn't that a strong predictor for stroke on all the trials. Yeah. But logically it makes sense. Sometimes it makes sense. So I agree with that.
Well, I think, you know, if you look at there is MRI data that actually almost, for the sentinel, they do capture debris. The clinical stroke is not relevant, but they do catch debris. The question really becomes that it may not leave them with a focal deficit, but we don't understand necessarily what happens to them down the few years in terms of their dementia and memory and, you know, just the subtle losses in their sharpness goes away.
Dr. Raza, are you using neuroprotection, and what were your thoughts on the Sentinel data that came out?
Yeah, so we routinely did Sentinel every single patient early on. So when Sentinel came out after the original Sentinel trial, we adopted it, and it added cost about $2,000 to our procedure. But we said, you know, we're going to use it in every single patient based on that. And that ended up using about 50 to 60% of time, because, you know, many people have small radials, spasm, you know, anatomy is not favorable. So when we tried to use on every single patient, it was probably about 60% we ended up using. But after the the TAVR, the protection trial, whatever the name was, we kind of walked away from it. So at this point, if it's a very high calcium, it is pure anecdotal. I agree with Alibai that there is no really data to guide us who are the patients who benefit. To be honest with you, the patient we think will benefit, like a 92 years old with diseased heart and everything, that is the patient the sentinel won't even pass through the radial because small tortuous radial and whatnot. So it's kind of a little bit of a dilemma on that people who really need it, you may not even deploy it. But at this point, we don't use it routinely. We end up using sentinel more often for basilicas, lampoons, Batmans, valve-in-valves, and then also, when we have left atrial appendage clot and we're going to do the suction, those are the times we use sentinel more often.
Bilal, what's your experience in terms of neuroprotection? Are you using it, not using it?
Yeah, so like he said, I think when it first came out for the first year, we actually used it very commonly. I would say 90% of the cases. Look back at the data for stroke for our own institution, there was not a whole lot of difference at all between when we did use it, when we didn't use it. So now we are a lot more selective. I think the cost is probably doesn't justify the routine use of it. So we try and customize it, but I don't think we have a solid understanding of the predictors like we talked about. So it's a little bit more of a gut feeling, you have a young person, high calcium score, you want to give them a surgical result, let's use it anyway. But the point is well taken, we've gone to a femoral and radial approach, we don't do bifemorals anymore. And I think that elderly patients have a difficult time with the tortuous aortas. And sometimes I wonder if you actually expose them to the risk of a stroke, which is the sheer manipulation of the catheter and the aortic arch as well. So that's something to be considered as well.
Wasn't this recent trial about protection was negative?
Negative,
yeah. So
yes. So the recent trial, that was Samir Kapadia's from Cleveland Clinic, that trial clearly was negative. There was a trend towards some benefit in major stroke, but overall stroke, there was no difference.
I totally agree with Dr. Bilal Murad that it's the long-term effect of it. I think it's the MRI data, if you collect it, it shows that there is something that is happening in the brain. It's not completely benign.
But
also keep in mind, in the surgical world,
by the
they have
MRI data,
tried
even with
everything
valve
and
crossing,
it has shown nothing.
you trying to cross the valve, if you were to look at MRIs, you'll have to see small emboli go up. So theoretically, yes, it makes all sense, but the data is not there right now.
Abdul Hakim, they're having a difficult time crossing. How would you approach it at this time?
If I can make a suggestion, please go RAO caudal view, and I think the rate at which you're crossing is less than 70 attempts a minute. Your speed has got to be more than the heart rate if you want to cross the valve.
Suggestion, Asim and Waleed, is that go RAO caudal because
of course it has to be like that.
Give you a better sense of the opening. And sometimes I pace the patient at 90 or 100 because it's tries per minute and also aortic valve opening per minute, which increases.
You have
chances.
proven to us that this is a critically narrowed valve. Okay, I think let's move on and cross the valve now. Let's go RAO caudal. You're playing RAO. Go more caudal.
More caudal, please.
And start with the non-coronary cusp. Point your AL towards the non. Pull the catheter back. It should look down. And see, one important principle is we all go in coplanar, but there is nothing like a coplanar. Coplanar is an illusion. You split 3 leaflets. But anatomically, that does not exist.
Yeah.
Okay, so now.
And so, and also if you pace the patient, I would pace them at 90, and that gives you more opening per minute.
Yeah, we will pace it. Just let's give it a go here for 1 minute.
So they are having a little difficulty in crossing, so maybe you can discuss any tips and tricks of crossing the valve.
So Abdul Hakim mentioned, so now you can see what I would do at this point is mac it up probably a bit more and take a dry cine, and you can see the opening of the valve that is just next to the pigtail that is going down. So a change of catheter might help you as well or something. So, and I don't use hydrophilic. I think this is a hydrophilic wine.
AL2, yeah, we have tried with AL1 and Terumo, and then we changed the straight tip Terumo wire into a straight tip 035 wide.
Sure, okay.
I think I agree with you. I would go AL2. It looks like you need to point downwards. The most important point is that the angle has to be right. It's not how tight the valve is. How is the angle of the AL1 to the orifice? That's what is most important.
See, in this view, the problem is your pacemaker is crossing right at the plane where you're supposed to see the valve. So come more caudal and then do a dry cine. Get that pacemaker off the plane of the orifice that's visible. So if you go more caudal, more caudal, more caudal, more, get that pacemaker off, get the pacemaker off, and now do a dry cine and see how the valve behaves. And then you'll know exactly where to go. Just do a dry cine.
So I almost never use a hydrophilic wire to cross the valve. Bilal, do you ever switch to it? I'm just afraid of trauma and LV damage. Using a hydrophilic straight wire to cross the valve, do you think it helps?
I do use that actually, and I think I've never had this much difficulty. This must be something anatomically here, perhaps a very eccentric orifice, but I do find that it actually helps.
It helps.
Do you use the hydrophilic wire, straight wire?
So, Waleed, could you tell us what are you guys switching out the catheter or?
Yeah, we are switching it, Osman, now to OL2, and we will try it with the straight end 035 wide. And if that didn't work, then we will try pacing it as well at the same time. But hopefully AL2, it will be a bit more committed, more down looking, so hopefully we'll be able to cross it.
Okay. And so at this point, do you have the valve prepped, or the valve has already been prepped or not?
Yeah, the valve is just prepped 2 minutes ago. So we have got Erdem here, who has joined us all the way from Turkey. And we have got our local trained Omar as well for the valve loading. He is the only valve loader here in Pakistan who is trained, and he's doing a great job. So guys, raise your hands as well. This is Omar and this is Erdem. So we have given a target to Erdem just to prepare it in 10 minutes, and he kind of got it prepared in 5 minutes.
So, Waleed, you know that this valve takes a lot of time in preparation. So do you think on selection of your valves, do you think that sometimes make you think a bit more, or is it this not?
Sorry, Ali, what was the question?
Oh yeah, I was thinking that the valve preparation takes a lot of time, but the new valve which they are going to come up will be quicker, isn't it?
Yes, it will be quicker. Theoretically, I know about it. Erdem, have you done any accurate prime loading so far?
Yeah, let's do that.
So for the prime? Yeah, so Erdem is very experienced in valve loading. I think he has done more than 2,000 accurate NEO.
So, Waleed, what we're going to do is we're going to do Bilal Murad is going to do a quick talk while you're crossing the valve. And once you've crossed, let us know, and then we'll come back to you.
Yeah, that will give you more time as well.
Thank you. Thank you so much. We will come back to you guys. Thank you. Okay.
Yep.
Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Pleasure to be here as always, and lovely to see the conference grow and thrive, and I've really enjoyed every session that I've been in. So my task actually is to talk about the concept that complex PCI should be performed in centers of excellence. And I'm going to try to keep it simple. I think it's something that brings together the science and the art of medicine, because you cannot have it just based on guidelines alone. So I'll carry you through some of my thoughts. So I think that if you want to have any evidence, you should look at the live cases that were done over here during these last few days. That every case that was done was of high quality, it was thoughtful, it was done by operators that were passionate about it. They did it in institutions that were well equipped and people who were well trained. And that really is the proof, ultimately, the outcomes is the proof. So let's go through some of the science behind it. So why is it important to do our absolute best? First of all, just philosophically, it's our moral responsibility that we should do unto others as we expect others to do to us. So if we want to be in an airline that has the greatest safety record, if we want to have our parents go to a hospital that has the best safety and the quality, then we need to make sure that we are, as individual operators and as individual institutions, provide others also with the same level of competency that we expect from others. Because ultimately, that is what everybody wants for themselves. Now, of course, there are guidelines, and we'll go through some of the guideline requirements. And then there is reality. And I think it's very important to keep that perspective that the reality is somewhere in between your personal opinion and the realities of life where you are working in, and then the guidelines that are developed in European and Western societies where the resources are sort of unlimited, and there is a lot of research based on certain population types. So you can't take the data from the Caucasian population in a rich society and interpret it and put it entirely in every country around the world, because we know the trials generally enroll 10% or less of patients who are screened. And ultimately, those guidelines are then applied everywhere. But data is data, so it is important, but we just have to keep that balance of it. So from a perspective of guidelines, they are invaluable. And the European Society of Cardiology and the American Society of Cardiology and SCAI all have their documents, and I urge all of you who are interested in this particular topic to reference them and read them and look at what their criteria are. I'm not going to necessarily go through these detailed documents, but important to know that these are not based on just personal opinions, but there's actually data. So let's start off. What actually does it mean? When we say complex PCI should be done in centers of excellence, we basically are breaking this up into three different parts. One, at the center of it is the patient. The patient is complicated. Therefore, he or she needs a complicated or a complex operator, but the complex operator cannot work in an institution that doesn't support complex PCI. So then let's start off with what are the requirements of that. What are the metrics for excellence? It has to be built on volume and experience. Remarkably, in the United States, the average PCI operator only does about 75 PCIs a year. There are over 5,000 cath labs in the United States. Not everybody is going to be a complex PCI operator. The procedural success rates, your complications, and how efficiently and how cost effectively can you do it and consistently get good outcomes is what defines you as well. So what really comprises complex PCI? There are four fundamental components to it. One is the anatomic. We've talked a lot about that in the conference. I'm not going to go into all the details, but the guidelines indicate that CTOs, left main PCI, but not every left main PCI is complex either. Bifurcation lesions, some are straightforward, many of them are complicated. Long lesions which in tandem require PCI with stents 60 millimeters or more. Heavily calcified vessels that require plaque modification with whatever tools that you have available. Procedurally, those which require imaging and coronary physiology, tools for calcium modification. They are wonderful tools, but you got to know how to respect them because they can be weapons if used inappropriately. IVL, fantastic therapy. Oversize it, you'll have a vascular rupture. OPN is a wonderful. If you don't undersize it by about 0.5, you have a vascular perforation. Knowing when to use orbital, knowing when to use rotational atherectomy, and what to do and what kind of sizing to do, those are really essential features. So, and of course, do you have the ability to support bad outcomes with hemodynamic support? Do you have the ability to manage complications? Post-procedurally, what kind of multidisciplinary care do we provide for them? What if the patient has a stroke? We think only about the procedural success, the stents inside, well expanded, everything looks good. What we don't think about always is what happened to the creatinine of the patient? What if they developed a stroke 2 days later? Do you have the support system to take care of the patient to the best ability as well? And of course, at the center of it all is the patient characteristics as well. And I think most of you already know about that. But ultimately, I really do believe that the most essential component of this complex PCI paradigm is going to be the operator himself or herself. So the SCAI documents that certain criteria for both institutions and for individuals. A complex PCI center of excellence must perform a minimum of 2 to 400. Now, there's a big range, and I think that's probably a good idea to have that fluidity as well. But you can be a low-volume center or a low-volume operator. If you want to be a complex a CTO operator, the SCAI documents, and I think European Society as well, do at least 50 per operator. Now, sometimes it becomes a matter of sort of a pride and ego for us, right? That I want to be known as a CTO operator. but you can't be doing 5 CTOs or 10 CTOs and do only one particular study. Not that you shouldn't be doing it, but recognizing your own limitations is really important. Doesn't mean that you should refer every single CTO to somebody else, but recognizing what you can do and what you cannot do. But understanding that if you truly want to be that center of excellence, there's a certain volume requirement. If you're going to be doing atherectomy, be someone who can do more than 20 per operator per year. Be consistent about using intracoronary imaging, and we'll come a little bit about that a little bit later as well. But these are, again, I'm talking from the guidelines perspective, knowing how to do bifurcation lesions, the different strategies, left main PCI, all these are very critical components that you're all familiar with. And of course, having the ability to do a multidisciplinary heart team approach with the surgeons, with the interventional cardiologists, sometimes with heart failure specialists, because if the patient's ejection fraction is 15 to 20% and you're doing a complex PCI, you need somebody who can manage the hemodynamics of the patient after the procedure is done as well. Imaging abilities, hemodynamic support, and of course the structural support from the institution. Do you have formalized protocols for dealing with emergencies, for complications? Does the institution support your ability by providing you with the toolkits? Do you have emergency pathways? Are you consistent about training your staff members? And what is the data that your institution is doing quality work? Do you do institutional sort of self-analysis, right? Soul searching. What am I doing? What are my outcomes? How many of my patients have MIs and strokes, or they are dying and they have complications from it, right? And what am I doing wrong? And so every group, every institution must look at themselves before they can claim. And then you have to, of course, benchmark it against your national registries. So centers of excellence have better outcomes. This has been demonstrated repeatedly in multiple different trials. The study after study has shown that centers that do more complex, more volume, and they have the support structure available, they have better outcomes when they do complex PCI cases compared with those institutions that don't. And you know, I don't want to go through every single line of this, but the success rates, the complication rates, the outcomes, the cost, the safety of the patient is more. And as you can see over here, for instance, the NCDR registry showed that more than 50 PCIs of left main per year, they have lower mortality than those people who do less than 10. So yeah, what about the ones that do 20 or 25 left main PCIs? Well, this is obviously, you know, it's not a black and white line. It's a whole spectrum. And we know that they have lesser complication rates as well. So if you work at a center of excellence and you do quality of work, data shows that your patients at 1 year will have less mortality, they have less adverse outcomes, and the cost for the patient also is less because you become efficient, you have less complication, your length of stay is less, and actually it's been demonstrated and again in studies. So now I'm going to quickly move away from the guidelines and really come and talk about some of the art of medicine that you can't really prove on in studies. One thing that I want to emphasize about every single live case that you have seen here from the operators that you've appreciated is the level of passion that they have. It's all about passion, passion, and passion. You have to have a personal commitment of evaluating yourself, a commitment towards excellence, not just towards yourself, but to your scrub assistant, to your nurses in the room. Every single person in that lab has to be a top quality individual. And not just that you achieve that point, because really this is a journey. There's no end point to this. You've got to keep moving on. You acquired one skill set, move on to the next one, and the next, and the next. It's self-learning. You don't work individually. You work with a team. I'm only as good as the ability of my scrub technician to manage that wire, because when that wire perforates the vessel and I have a complication, I can be as good as an operator, but my complication rate is mine. That's for me to control. So it's my job to make sure the person next to me is of a high quality. So collectively as a team, we have to have that ability to deal with complications. So the hallmark of institutions and individuals who want to achieve centers of excellence is that they have an attitude, it's a mindset. The mindset is, I am going to seek excellence as a team in every aspect of the procedure and patient care. It's a culture of growth. It's a culture of expanding your skill sets to include everybody. This is not an exclusive me, myself, and I. It's not about the individual, it's really about the patient. And so you need an entire team. So everybody needs to grow with you, because when everybody grows, you grow and your patient, your entire program will grow. And through word of mouth, patients get to know that this institution is of high quality. So you can have an outstanding operator in an institution that doesn't support, and the physician cannot thrive the way they want to be. You can have an amazingly beautiful hospital, but you don't have physicians that are committed, and you will not be able to thrive into a program as well. So you need component of both. And that comes at a level of personal acceptance of your humility. You're going to have complications, seek the assistance of people, engage in research. So these are some of the my personal thoughts. I'm going to end with this slide. Personal opinions are valuable, can't ignore data. Evaluate existing systems. I think PSIC has an important role to play here in Pakistan. Evaluate your training programs. By doing so, be honest about evaluating the trainers ahead of by evaluating the trainees. Are the trainers capable of training the trainees that are coming out of the programs? Because the trainees are not good in quality, something is not right in the feeding line. So we've got to look back, and everybody has to see, do I meet these criteria or not? Am I doing imaging enough or not? And I understand that there are limitations, but the fact that we don't have the tools here doesn't mean that that makes it okay. We have to adapt to it. Yes, I get it, but there are certain circumstances where you must do it. And then again, never lose your passion to succeed. So I'm going to stop here in the interest of time. Thank you.
Thank you, Bilal, for a very comprehensive view of the essentials that are needed to run a complex program and have excellent outcomes. Are we going back to RSC? Perfect. So I think they've crossed the valve, and we'll catch up with RSC and see where they are in their procedure. Asim, assalamu alaikum again. It's we can see you. Can you hear us?
So Jawad, take us back to the views where.
Can we check the sound, please? Waleed, can you hear us?
Yes, we can, but can you hear us?
We can hear you. Yes, we can hear you.
Excellent.
Can you catch us up to
Excellent.
where you are in the procedure?
Yes, so I think just after you guys went offline, we just went back to LAO, that is our comfort view to cross, and we just crossed it with the AL2 and a straight tip 035 wide. And then we took gradients, and we also, while we were waiting for you, we guys did the pre-dilatation with a 20 balloon. Can you please show us? Can you zoom this, the camera on this screen? Just play this one.
So I would be careful with your wire position if you... okay, so
yeah,
nice dilation with the 20 balloon.
What were the gradients?
Yeah, just show us the balloon dilatation again. Just play that floor again. So if you guys can see, there is like quite a lot of calcium and indentation in this 20 balloon. So it is behaving and looking more calcified than actually it is. When we were doing the baseline iotogram as well, the right cusp is very calcified, and that's what actually was giving problem for crossing to the LV. Dr. Bashir, coming back to your question about the baseline gradients, they were significant, but somehow they did not get recorded. So now we have the valve. We are going with the valve in now, and we will come down to the right femoral while Asim Bhai is crossing. Go up. Okay, keep going in, keep going in.
So interestingly, with this platform, the sheath pressure is maintained even when the device is through it. So you don't need, so you can still be connected for your A-line to the sheath and still get pressure. And you can see that once the valve comes through, you have good pressure tracing.
Okay, so we have now crossed the valve, we have now crossed the aortic arch. Now what we will do is we will take a pause here, Asim Bhai, and what we are trying to demonstrate here to our colleagues is how to align the commissural posts.
Could you zoom in? Could you mag?
We will do that. Before you guys zoom in, go on a magnification, go mag. And we will then be taking a cine on at a 30 frame per second. And just Asim Bhai, bring the, and we will go to the 3 cusp view. So we go to the 3 cusp view, which is LAO 16, caudal 5. And Asim Bhai will bring the valve a little bit out, just chorus, just so exercise a bit more on the top.
So you could center the valve so we can see the commissures.
Center, excellent. Now at 30 frames per second, we will do a dry cine here. Do not inject.
Okay.
Okay? Just give us a few seconds to do this adjustments. Right, Sini?
Valve a little more in the middle. Upper wala part, that's it.
It's good.
Keep it here.
It's good. We can
No
see.
injection.
We can see.
So I think are going to have to clock this several times, as you see one.
Exactly. Yeah. So as you can see, and Abdul Hakim, can you kind of explain why you want to clockwise it? Because the two commissural posts, if you see on the outer curvature, they are overlapping. So what we need to do here is, technically, we need to kind of clarify this. We will be counterclockwizing both the sheet and the delivery system. And then we will let it go because we don't want this torque to be accumulated there. So what Asim Bhai and Salam Bhai will do is they will kind of go live now. They will clockwise both.
So
And
you
then they
can
will
see
let
that
the
there's,
system
in
go.
the three-cuss view, there's two commissures on the left and one on the right. And the free cell is only one free cell. So in the three-cuss view, you should see two free cells, one on the right and one on the left. And
Just
you
to
can see, you should be able to see a 1-1-1 configuration on the commissures in the three-cuss view. So 1-1-1 configuration, two free cells sticking out in the three-cuss view. So when there's only one free cell on the right, then you turn right. And you can see as they're clocking it, the other free cell
So just
is
take it
popping
right,
out.
Sini. Take it right, Sini.
And you'll see a
Yeah, so it's
kind of a
slightly
1-1-1.
over, as you can see, yeah, but you can see the right free cell now, just a bit
So, so I
this
think
way.
you overclocked and they'll have to go the other way.
Yes,
There's,
yeah, so we are coming back slowly. It's slowly, just leave the system in a very neutral position.
So there's a little lag in when you clock the system or counterclock
Yeah,
the
there
system
is.
and when you see it on the floor. So you can see it coming around now.
Yeah, yeah,
Yeah,
so
that's good.
that's kind of the perfect position.
Yeah.
So you can support the free cells and you can see the three commissural posts.
Yes,
But-
you can
but
see the
there is
posts.
a caveat here as well. But
Yes.
there is a caveat here as well. It can be all the way wrong. So what we need to do is we need to come to the two-cusp view now. So the two-cusp view over here is going to be RA5 caudal 24. And we need to make sure that the right free cell is towards the right. I don't see. Okay. Ritmidol, can you see me now? Okay.
You look good.
Yeah, so that's good.
Yeah, that's very good. So we now go back to our three-cusp view, which is LEO 16 caudal 5. And any comments, any questions, any suggestion before we start crossing the valve?
Valve को middle में कर दो.
I think you
Bring the
report
valve.
the inner curvature as you cross.
Excellent. Yes.
But you have to be mindful because you may lose your alignment. There may be torque built up. So I think just be careful as you advance.
So that's kind of a very, very crucial point, Abdul Hakim. So this is what we call as a neutral position now, neutral in a good way. Now we will be starting pushing it in here and we will maintain that neutral position with a slight push forward. That will help us in aligning the whole delivery system on the outer curvature. So go live. Okay, thank you. Asim Bhai, keep pushing it down. So what Asim Bhai is going to do to take that radio opaque marker to the lower end of the...
So very slow there.
Now,
So that's good.
it's just slow. Do not cross. So because it is a medium-sized valve, so kind of what we will try to do here is that the radio opaque part, if you can see it, is just should be kind of half at the lower end of the pigtail. So we will do an iotogram over here as well. Simba, just try to kind of let's do an iotogram here before we do anything.
Go slightly further down. We
Yeah.
need to push down further.
Yeah, I just want to see that our
Okay, you
pigtail
want
is
the
in a good
autogram?
position as well.
Let's get ready for autogram, please. Okay, let's do it here. Inject, please.
Okay, so
Very good,
iotogram is in a
alright.
very good position. It's the lowest end of the cusp, and I think we are good to go now. We are good to cross. Keep the wire hold.
I'm going to go slightly down.
So at this point, it's important to go very, very slow, just a millimeter at a time.
That's it. That's it. No more pushing. And we will repeat the aortogram again.
Inject, please.
I think it's very important for the primary operator to maintain that forward push with the left hand and not release that tension, because I think that's the most important point here.
I would say it's still slightly high to my liking, but I don't know what the other things.
I think a millimeter in.
Ali, you are absolutely right. We are going to give it a slight forward push. Slight forward push. Asim Bhai, maintain that. That's it. Maintain it.
Okay.
Maintain it.
Okay.
So you want the marker at the bottom of the pigtail.
थोड़ा और दे और maintain करे उसको, हाथ नहीं हटाना.
Is that fine?
Okay, that's fine. Aortogram, last one. Hopefully will be good. Maintain करे Asim Bhai आपका.
Looks good in relative to the pigtail. Let's see on the.
I think
that's
looks
good.
Yeah.
So, yeah.
That's looking very good.
So now Dr. Salam is going to start opening the upper crown. So he will be going slowly on the knob number 1. Keep going slowly. Keep going slowly. Keep going. You're doing a great job.
So Usman, is a slight tug forward. Is that correct?
So slight forward pressure on the system.
A slight push forward. So if you guys can see the upper crowns coming out, stop here.
Yeah.
Can you see? So we will repeat an aortogram here again. Aortogram, please.
Ready?
I think you've moved up a bit, so you're going to have to push the system in.
Yeah, a little bit. You need a
Slight
little forward
push, I think
pressure.
it will be okay. And maintain that forward.
Yeah. Slight
Maintain
forward
that
pressure.
That's it. Let's keep that forward, Asim Bhai.
Is that
Slight
good?
push forward.
Okay.
Yeah, it's okay. We will repeat another aortogram. It looks fluoroscopically good.
Ready?
Aortogram, please.
It's coming up.
And so
Inject,
the
please.
patient remains very stable throughout the deployment, so
Yeah,
you can
and
see that
push,
the
push.
pressure is good and the valve isn't obstructive at any point.
I have. Want me to go further down? So that should be okay.
Just slightly pull the wire.
So
slightly.
That
main
looks
thing
good, I think.
At this position now is that you have to keep the forward pressure because it did come slightly up from the first initial point.
Just because we have done some fine adjustments, we will do the last aortogram before we release the stabilization arches. Aortogram, please.
Inject, please.
I think that's all looks good.
That looks good. That's good.
Okay. Just Salam, go to the far end on the 1. So, and if you guys can notice, keep going, keep going. Yes, the stabilization arch is
Just for the sake of audience, a lot of them may not be familiar with this valve. So this is not retrievable. Once it is deployed, it's deployed. So you have to
Fluorostore.
take the
Fluorostore, keep that.
I mean, you can, of course, snare it all the time. You can snare it.
Yeah, you can snare
This one is
it.
bad for snare. This is very bad because these crowns actually sit on the leaflet. So
So you can snare it and pull it up, but can't remove it out of the body.
Yeah.
Yeah, and as you guys have noticed, no pacing required during this process. We will do an aortogram. We are just filling up for the next aortogram at the moment. And if you are happy, then this is the time that you will be pulling our pigtail back.
So the patient's rhythm and blood pressure is very stable, and the valve position on fluoro looks very good.
Yeah.
Do you plan on pacing, Waleed, during the final deployment? Do you pace or no?
No, Usman, not really.
Not really.
Just it will be very quick, and I think we're in a good position. If I do have any concerns about the position of the valve, then definitely I will consider pacing. But it looks all good.
Adil, आप करो. हम पकड़ के रखते हैं.
Okay. Right. Okay, are you ready for aortogram? Okay, aortogram.
So
I think it looks good.
It looks
good
good.
here.
It looks
Yeah,
good. But I would keep that slight forward pressure.
Yeah, Asim Bhai will keep the forward pressure while pulling the pigtail slowly. Yes, keep coming back. Yes,
Keep-
good,
yeah,
excellent, Asim Bhai. And now we have lost kind of no need of the pigtail. So now Salam Bhai is going to remove the safety pin, which he has done. He is so much excited to do this step. Now we will go live, and please notice the movement of the valve. It will be going from the outer to the inner curvature. We will do Salam this step very quickly. So go live and turn.
And
Excellent.
See the nose cone as well. So the nose cone always goes down as well. So.
Okay. Thank you, guys. And both of them have done a great job, because if you look at the end of the valve, all the commissural posts are very nicely aligned. The valve is open nicely. The valve movement was very stable from the outer to the inner curvature. And as Ali mentioned, the nose cone moved very nicely down. Now, what Asim Bhai is trying to retrieve this, you can pull the wire further.
Remove the nose cone. I know before Hakeem says it, can we go areocaudal and look at the valve structure?
You mean areocranial or caudal?
Caudal, cranial, both.
Okay, don't you want to pull the wire inside the nose cone? You've got to be careful here. I would pull the entire wire inside the nose cone, bring it to the middle, because you can really pull the valve out.
Excellent. Okay, come to the descending aorta, so we can't do much with the delivery system anyway, so there is no any point now to keep it. Come to the descending aorta. Pull it back to the descending aorta, Asim Bhai. Sure. Okay, show us in the descending aorta. And now Salam will do these steps in a reverse order. So he will do the two first in the opposite direction. Rotate this in the opposite direction. Keep doing it. Okay. And then he will do one. Now again in the opposite direction. Keep doing it. And as you can see it fluoroscopically. Excellent. Okay.
Flora.
Okay, what was the comment? Do you guys want to see the conformation of the valve in an areocranial? That was we were discussing?
I think you should do an aortogram now, and then maybe decide.
Abdul Hakim, before I do an aortogram, I change it. That's the benefit of the eye sleeve. I take the delivery system and I change it to pigtail. It gives the few minutes to the valve as well to kind of extend, so we will do that. That's the extra advantage with the eye sleeve. You are not bothered to put and not worried to put a +4 sheath, the delivery system and all that. So you already have got the sheath in there.
So Waleed, we're running behind on time. If we could see the aortogram, so that will show all of us the valve position.
Aortogram is coming. Let's check the reddish aortogram. And I think for the aortogram, Asim Bhai position is very good over there, because we'll be just coming, we are not coming below the commissural posts, because that's where the coaptation of the leaflets of the accurate NU2 valve is. We will be just kind of trying to position it at the mid or above the commissural posts. 207, give 3,000 more heparin, please.
I think those are very important points. The stiff wire tends to push one of the leaflets, and if you see a lot of AI, that could be just wire related. So once you put the pigtail, try to bring that more central, and then do an aortogram. Otherwise, if you see AI, you're not sure if it's wire related or PBL related.
Yeah. So
the other important thing with this valve is that the leaflet resting position is open, not closed. So we had one case where we had a stuck leaflet and had to do a light balloon inflation to get it unstuck.
ये सलाम भाई कर देगा. सलाम ऐप्स को सेट करें. आप दूसरे पिक्चर जरा सा बाहर निकालें. हाँ बस थोड़ा अंदर. That's fine.
That's good.
Okay. That's good. इससे ज़्यादा नीचे नहीं जाना. थोड़ा पीछे. Okay, ready for the aortogram? Okay, excellent.
And your gradients look good on the hemodynamics, and your
yeah, it's almost zero gradients. बहुत पीछे आ गए.
Good diastolic separation. So
aortogram.
That looks beautiful.
It looks great. Looks great result.
Thank you so much, guys. Thank you, and thanks to Asim Bhai and Salam Bhai and to our loaders and to the whole Catlet team. Excellent job, everyone.
Thank you very much, RIC. Great case. So we're going to move to AFIC for the PTMC case. So quickly present the case, and then is Dr. Tariq Abbas here?
Assalamu alaikum. This is the brief clinical summary of a patient. A patient is a 26 years old female and she presented with dyspnea Naya class 3 for the last 5 months. Her clinical exam showed a tapping epic speed with a loud S1 and a mid-diastolic murmur. We proceeded with baseline labs. It showed HB of 9.7, other parameters were normal. This is her ECG and it showed normal sinus rhythm with no features of any chamber hypertrophy. These are her transthoracic echocardiographic images showing M mode with a dilated LA of 4.9 centimeter and LVEF of 68%. A focus on valve morphology showed thickened mitral valve with diastolic doming of anterior mitral leaflet and restricted opening. Her mitral valve area by planimetry is 1 centimeter square, and by pressure half time it came out to be 0.9 centimeter square. There was no significant MR. Her PAP was calculated to be 50 mm. Her comprehensive Wilkins score was 6. So therefore, we proceeded with transesophageal echocardiography, and it shows no presence of clot in left atrial appendage or LA. There is no significant MR. And this is a 3D reconstruction, and it showed thickened leaflet. So this is a case of symptomatic severe rheumatic mitral stenosis, and we will proceed with the intervention.
Thank you.
Thank you.
I would like to request Dr. Naveedullah to moderate this case, please.
Bismillahirrahmanirrahim. Okay, can you please introduce the operators?
Can you hear me, please?
Yes, we can hear you clearly.
Okay, I welcome you to this
Can you
live
please,
transmission of a case. We've got a case of percutaneous mitral commissurectomy, which will be transmitting from AFIC Cath Lab. I've got Dr. Mohsin with me, who will be doing the case. I am Dr. Yasir. I'll be assisting him. And we'll be lucky enough to be proctored, guided by Dr. Nadir, senior interventional cardiologist. We have got our Cath Lab staff, Mr. Ghaffar, Mr. Amir with us, and radiographers Bilal and Khalid, and Miss Naima as our nursing assistant. So,
I have just comments about this mitral valve. So most of the time, what we do, we select the balloon according to the height and the surface area. What about to have the best result and how much we can overstretch this valve? Like that's one method is to look for the commissures. So I need the opinion from the experts who are doing a lot of it. So how much we can overstretch? Like you go about the height, but can we further stretch it to the extent so that we can give the best result to our patient in a long term? And
I think the operators are ready to proceed for the procedure. We'll take the question after because they are already there, and they have usually we don't give heparin at the time, so we don't need to wait long and we need to proceed.
Okay, thank you very much. Welcome to all of you. Can you hear me?
Because we have got incidences that you get thrombus in the Mullen sheet when you are waiting at this point of time.
Can you hear me?
Yes, we can hear you.
Okay,
so
thank you very much. So I'm going to show you the live puncture, septal puncture now. So what we'll do is, I'm going to come around, this is AP view, and I'm coming down. This is the pigtail. I normally come half a disc below.
I think your pigtail is in the right coronary cusp. You may want to put it in the non-coronary because I think that changes where you puncture. So I would work on that pigtail and bring it in the non-coronary.
Very nice comment. So what we do is, what we do is, once we take up the pigtail, we make the circle of the pigtail. See, can you see this? To my left of the screen. So this is one way of having reasonably sure that probably I'm in the non-coronary cusp. Can you see this? If this circle is inside, then I'm most probably in the right. But I fully agree with the comment, but I'm just ready to puncture. So, RU30 please.
So do you take the LV?
I'm half a disc below.
Do you take the LV gram to help you with the stick or no? Do you take the LV gram?
We can do it.
So we will do the LV gram once we are inside the LV and positioning the Inouye balloon in the mitral annulus. Not
okay,
before that.
so I'm happy with my RO 30 position, and I'm going to go true lateral just to see whether I'm truly away from the aorta or not.
So what's your strategy?
So
You want to cross?
let me show you. Iski spine dikhaiye zara. So it should be 1/3 from the spine and 2/3 from the aorta. Can you see it here? And I think I'm happy here. AP mein aa jaye. But I never puncture here. Come into AP. Because at times you can go to the lateral wall of the RA. So I position it here, but I always puncture in the AP view. Okay, I'm happy here. I'm going to puncture now.
What's your cursor position?
A picture, please. Can you see it? I'm in the LA. And the reason of taking this picture is now I'm exactly sure where is the superior level of the LA. So that I should not. Now, what I'm doing is I'm withdrawing the needle and slightly pushing my Mullen's sheath. And then I will aspirate just to see the color of the blood. So I'm aspirating. Can you see this? It's bright red. So I'm reasonably sure that I'm in the LA. Now, this is the loopy wire. This is 0.025 inches. This is known as the loopy wire. So I'm going to take it up for you.
See, while he's doing that, I'll tell you, I learned PTMC from Naveedullah Saab. Each time I get stuck, he comes and bails me out. And he's got a really nice way of doing transeptal. Can you tell us how you do it, Naveedullah Saab, with contrast when you start? So I think it'll be great for the audience. His technique is probably the best, doing it fluoroscopically without echo or ice.
Like it's not my technique, but I've learned from my seniors because these are the things which we learn from.
So I'm going to take this dilator. This is 14 French.
Can I ask? Sorry, go ahead.
Because they are at a critical point and they want to show us something. So do we need to discuss right now? Okay, so basically what we do is
so I'm going to do the septal dilatation now. Thank you. So here I am through the septum. There's no need to take it any further. Can you see this? I'm through the septum now. So her height is 159 centimeters and we have taken 25 mm balloon. 26 mm balloon, but we normally start a bit one step down, so we'll start it from 25. So now what I'll do is, I'll just do like this, to and fro movement just to dilate the septum. And if there is severe resistance at this point, I'm sure that probably I'm not through the fossa and through the hard tissue, the muscular one. But I think I'm okay because it's going freely. It's not giving me much resistance. Okay, I'm happy here. Now I'll dilate the puncture side.
So for the panel, just, there's a lot of data to show that TE-guided PTMCs have less procedural complications, shorter procedure time, less fluoro exposure, and less incidence of MR. So I know in Pakistan we generally don't do image guided, but thoughts on that, and why do we not use TE in cases that it's possible?
That's what we always say, that because we are following data from the Europe and other areas, and they don't have this problem. And we are the one who are facing this problem. That's why we always ask our colleagues that we need to develop our own guidelines, because when we have been doing these cases for the last more than 15-20 years without TE guidance, and usually there are no complications because at NICVD and PIC and other areas, we usually do more than 400-500 PTMCs a year, almost daily, and sometimes we do 10 PTMCs a day.
So maybe a randomized trial of TE versus
we have done
fluoro-guided?
6-7 cases
I can tell you my
with the
experience. When I moved back from the US, obviously everything was done under TE guidance. And I was really scared. I had a patient with PTMC. I'd done PTMCs in the US, but in our own very controlled way. So I called him. I was like, I want you to hold my hand, stay in the room with me, tell me how to do it, okay? But I think he's got a really nice technique. Can you please describe that when you give contrast?
So,
it gives a lot more confidence.
Once my,
can I make a comment?
This hub is through the septum, what I'll do is always do metal to metal and then metal to plastic. This means when I'll go in, I'll do, first of all, can you focus on my hands? I'll just detach metal from metal. This is extremely important because if you detach the metal from the plastic tube first, the balloon will be deformed. So that is a crucially important step. So I've removed the metal part and I'll take it to 6 o'clock. So this is 6 o'clock. Now I'll remove the metal to plastic one. So I've done it. So metal to metal, metal to plastic, and just remove all of it. Okay. Are you 30 mein aa jaiye? Now we'll do the hemodynamics for you.
Okay, because considering this doing TE in every case, basically there is a debate in NICVD about this, even to a level before that this procedural TE, because we were doing PTMCs for the last more than 15 years, and in the last 2 years we are doing TE before each procedure, but before that one we used to do 400 PTMCs a year. And in those PTMCs, we had a protocol that we do pre-procedural TE only in those patients who were in AF or who had a large LA or a history of stroke. Other than those cases, we have been doing PTMC without TE. And 300 PTMCs, 400 PTMCs a year. So our stake was that we are living in an area of evidence-based medicine. And evidence says that for the last 10 years, we never had a stroke. And the stroke is something you don't say that you never reported. You didn't come to know that this patient had a stroke or usko छुप गया होगा पता नहीं चला होगा. Stroke हुआ तो वो तो उसी वक्त सामने है. So we usually ask our colleagues that we come up with the data and say, do we really need to do TE in every patient, every
diastolic gradient on the screen?
Or besides the question of doing TE in the procedure, even before procedure, do we need to do TE in every patient? Because this was the practice for the last 15 years. And we were doing more than PTMCs than more than we do PCIs. We used to do one PTMC every day at NICVD and PIC.
We are just having some discussion here. Just give us 1 minute.
So in that regard, we always say that we need to come up with our own data and we need to come up with our own evidence and see that what are we need to develop our own guidelines. I think this is a good forum that we all sit together and make a team for it and decide our own guidelines.
So Naveed, you have like so many cases, so
yes.
You haven't looked at your own data so far?
Basically, people ask us that you give us, we can say this is evidence level of C.
Oh, yeah, your experience.
So
you want to say something?
That we have
I want, because we have done so far.
Yes, sorry.
So you go ahead.
Yes, please.
For 400.
Okay, so can you see the pressure tracings?
Mike.
So the LA mean is 22, 23, and there is a significant end diastolic gradient between the two. So now I'm going to try to put my balloon in.
Mohsin, aapko hamari awaaz aa rahi hai? Are you able to listen to us also or no?
Yes, sir, we can hear you.
So, okay, so I know because you are talking there and so unfortunately we are discussing here. It doesn't look like that we are hearing each other. So we are having some discussion with the panelists quickly and then we'll come back to you in 1 second.
So we have done so far 400 cases and recently we shifted to TUE guided and we have done so far 6-7 cases with TUE guided. And that was an excellent, like, you know, it doesn't take a lot of time. You are right there and your septal puncture, we know fluoroscopy, of course, with the experienced people, they have done so many. But that adds to the beauty. You get right to the PFO and you had an integrate entry or nuts like going through the commissure, through the cordies in a beautiful way, and the results are excellent. And another thing is that very minimal chances of MR. So we are probably planning one of the study, which will be a pilot study to look at compare fluoroscopy guided PTMC with TOE. So that's one we are moving ahead with that. As I was discussing, there are a couple of really nitty-gritty things. I looked at some of the cases, like in these 400 cases, there were bi-commercial calcification. One of the things which we ignore, and they did the worst with a leaflet tear and with a severe MR. So one thing we come up from our own data was that bi-commercial calcification do the worst. And another, yes.
Yes, basically that's what we
Can I add one thing? This is Dr. Javed from NICVD.
Can I correct the
last week?
NICVD we started doing in 1993, and we started with Inouye balloon, and then followed by the metallic device, and finally multi-track balloons. Now, talking about the TOE, yes, we started doing TOE, and mainly it was only in those who had atrial fibrillation, and there we definitely went on to do a TOE first before doing the procedure. I only had one patient who developed TIA and a stroke, and so it was something that, difficult to know why she had it. She was in sinus rhythm, and there was no reason to do TOE in her, and we did a procedure which was successful, and 24 hours later she had left-sided hemiparesis, from which she recovered completely. And yes, I do agree that on seeing the mitral valve commissures on the short axis is very helpful to know how much is the calcification at the commissures, because that helps to guide the prognosis and the ultimate outcome of the procedure.
Last week I was doing this with PTMC patient who has atrial fibrillation, and we did TOE and transthoracic and transesophageal. No clot was there. But unfortunately, when we completed the procedure, then patient become disoriented, and fortunately we have a stroke program running in NICVD. So suddenly that stroke interventionist was there available, and he did cerebral angiogram and found a clot in middle cerebral artery. And finally, he completed his stroke intervention, and patient on second day recovered. So this was the first time we have seen a stroke in a patient who we have already done TOE and transesophageal without any LA clot. So that's the experience.
So that's what, okay, I think they're ready to cross the valve. So
Mohsen, go ahead, please. Just show us what
okay,
you
sir,
doing
we are
now.
going to cross the valve now. What we do is we slightly pull, and I'll anti-clocks my balloon now in RO30. Once the balloon is on the mitral valve, there's a bobbing movement of the balloon. And can you see this? Save that.
Beautiful.
Yes.
So I'm in the LV, but remember, we can never be sure that you are in the LV or RV. So what we do is, go LO30 please. We always go LO30, because remember in RO30, RV is in front and the LV is hiding behind it. So just to be doubly sure, you're safe with GS. See, my balloon is crossing the pigtail catheter. If it doesn't cross the pigtail catheter, then remember we can be in the RV. RO30 please. So this is just to doubly check it. So just slight pull and anti-clockwise. No need to rush, no need to make aggressive movements. Okay, so I'm happy here.
Can you maybe tell some other techniques if you are not able to cross like this, what else you do?
Sir, this is an excellent question. What you can do is, in case of, number one, remember that the 90% of the reasons that you're not able to enter into the LV is a low puncture. That is the reason I did not go one disc space below the pigtail whilst I was puncturing. If it's a high puncture, it is very difficult that you fail to enter into the LV. This is one. But still, if you fail, what you can do is, with this catheter, this balloon catheter, you can take a picture in the RU30 and so that the LA is delineated. And that very nicely shows the junction between the LA and the LV. So we know that here is the mitral valve. So now what we do is, because we had a couple of cases in which we thought that we had expanded well, but in fact it was in the subvalvular apparatus. It was thickened and we thought that we are okay, but we were not. So what now we do is that we'll give a pigtail injection just to be 100% sure that we have got the annulus. Pigtail pe aa jaओ. And we'll demonstrate it to you now. That's good.
Sometimes in NICVD, when we are confused, we just connect with the proximal port of the balloon and we see the pressure. If the pressure is in the LV, then it's easier to see. So there are different ways.
That's a nice idea, sir. That's a nice idea. Acha ji. Picture नहीं लेनी, fluorosave करना, ठीक है? So we'll do a fluorosave. Okay. So now what you do is, Dr. Yasir will inflate the distal balloon. Doctor sir, inflate कीजिए, and keep it there. There's no need to rush. He has inflated the distal balloon. Now what I'll do is, I'll just gently pull it backwards till I feel resistance. Now I'm feeling resistance. Inject please. And go up, Yasir. Go up, full and down. Save करें. Okay. So this is how we do it.
Yes, usually we usually take the stellate out, and so that the balloon gets free to move in the LV and gets in the orientation
Let's
with
see
the
the
LV.
gradient now.
So you take the stellate out or just pull back?
Pull back and keep it in IVC, or sometimes so that
You know
it's
what?
not putting any stress on the LV and it's not the balloon remains coaxial with the flow.
Yeah. So now I'm removing the stellate, and we'll demonstrate the hemodynamics now.
So, Dr. Naveed, just
So first the
with the
hemodynamics
balloon
and
as
then
well,
the echo.
when it pops up, is there any data that suggests that it shouldn't come back like this, or is it just the normal practice, or do you have to push it forward slightly to reduce? Has it got any correlation with MR?
Usually, yes. Usually, you are afraid of that. You might have caused MR, but it also depends on your second operator. उसने नाश्ता सही से किया हुआ है, वो भी stressed. And your first
Okay, we'll
operator.
see it. Let's see whether we have done MR or not. We can see that.
Usually when you are doing
and
with
remember,
your
it's
fellow
very
from
easy to
KP.
see on the hemodynamics.
So you're stressed and they pull things so
Mohsen,
hard.
Mohsen, I don't know if you have done or not, but I think Naveed and I was asking the other day, Dr. Tahir Sagir also, have you done PTMC in if somebody has a left atrial appendage clot? Obviously not the left atrium, but left atrial appendage clot. And if yes, then what precautions you will take, obviously, that your catheter doesn't go into the left atrial appendage to dislodge that clot?
I think that
excellent
I'll say
question.
that we
So,
have
in
done
fact,
around 7 cases.
जी बताइए मोहसन, आप बताएं पहले.
Okay, excellent question in fact. So, number one, I haven't done it because I'm in the army. And number two, yes, you can do it.
That's a good one.
There is a classification, there is a Manjunath classification in which they say that if the clot in the LA appendage is not popping out of the LA, there's a proper classification that you can do it. But how to do it? This is probably one of the few reasons why you want to go low. If you go a low puncture, septal puncture, what happens is you are very near the mitral valve. And in low puncture, you can easily go into the mitral valve, through the mitral valve into the LV. So the trick is not to do a high puncture if there is a LA appendage clot. Can you see the hemodynamics, please?
Yes, we can see that.
So see the, yeah. So the difference, if you remember from the previous one, is almost gone in the tracing. And now we can show, and remember, look at the LV tracing. If had it been a significant MR, remember the LA tracing just follows the LV tracing, because once it's MR, during systole, the pressure of this pink curve should follow the LV curve pressure.
Sure.
So this is a great way to show, probably there's not significant MR, but let's check it from the echo. Can you please focus on the echo?
Okay, so you went for 24, you started with 24?
Sir, we started with 25.
Okay.
Required was 26, but she's a young patient, 26 years old, no calcification, nothing. So I got 1 mm down.
Okay.
And can you see the can you see the echo? There's mild MR,
Yeah.
but there was a trace MR initially as well.
Okay.
And let's see the short axis now.
This is,
There
the MR is more
has
than a
slightly
mile.
increased.
Yeah, it's more.
Yes, I agree. And let's
Yeah.
see whether we have
So I think I'll stop
done it
here
or not.
instead of going any further.
Can we see the 4-chamber view
Fully
on the
agree.
echo?
So can you see the anterolateral commissure, which is split?
Yes.
The right one? Aerial area.
We can see that.
Is it split
Okay,
or
so-
tiered? So sometimes we with this SIM balloon, unfortunately, we have seen so many MR. So we were using SIM. We have used more than 100. I think 150 SIM balloon. Now recently we shifted to Hanoi balloon. With this SIM balloon, I don't know, the rest of the center will share their own experience, but what we experience, it's more stiffer, and it sometimes even can go the way like you have a little bit push. Even we had one of the complication, it went out of the lateral wall of the LV, so that patient was taken to the OR. So SIM balloon, our experience was not that good as compared to Hanoi, which is the best one. So I want to know from other center who are using the SIM balloon.
I haven't used it. Have
We
you?
had.
And the MR was more as compared to Hanoi.
We had some balloons. They went to us for the trial basis. So we
Yeah.
checked those balloons, and we found out this is more of semi-compliant kind of thing. So it stretches more. So that's why we in our practice, it's always a protocol that you always check the balloon size before you insert it into
that's
the
what
body.
we do too.
So that is the thing that in these patients, when we saw this thing, that if it is 25 on the syringe and you put 25, sometimes it's 26 or 27. So it's more stretchable.
So the valve,
and
so the
that's
valve
why
area
we
has
stopped
increased
doing
from
those balloons.
0.7 to 1.6.
We are no more using these
Looks
balloons.
good.
Same is with.
Okay,
So
so
I
let's
think-
take.
Yeah.
So we are taking a LV angiogram as well because of, let's see how much bad is the MR. Ready? Ready? Good injection.
Yeah, but
Injection, please. So can you see this? So there is no significant, yes, mild, I agree, but there is no significant MR
Yeah, it looks good.
on the LV angiogram as well as on the hemodynamic tracing. And this patient already had mild MR to begin with. But yes, I agree. So we are done. The area is 1.6 with one commissure split, and we are happy. We are not going to go any further.
Yeah.
And now let me show you how do we remove it because of the risk of a stitch puncture, which is very, very important. People normally forget this. So you can, whenever you puncture, there is a risk of getting a stick puncture. How to avoid this? That if it happens, what is the safety mechanism? So I'll show you now.
Another issue with this balloon is that the tip and the only proximal marker is radio opaque. Sometimes you need to rotate your system and you want to go with the reverse loop, and you rotate your system and you kink the shaft. So
Okay.
in this
So
patient,
remember
if you
again,
don't see
I'll
the shaft,
attach metal to
that
metal
can cause
first.
trouble for you. So that's why we don't
Metal to
usually
metal.
use this system.
And then metal to plastic. Can you see this? And what I'm doing is, I'm keeping my loopy wire in the LA. Now I've removed my balloon. If there's a stitch puncture, remember, there is number one, pericardial effusion, and number two, there is a sudden drop in the blood pressure. And if it happens, and it has happened to us once, what you do is, flush please. What you do is, here's the pressure, we check it for 2 minutes. See, the blood pressure is good. If it drops, for example, and there is pericardial effusion, what we do is,
Yes,
I'm
we
just
at
demonstrating
NICVD
it, that what you do is you
So
simply
we're going to talk about,
take this
let them
balloon.
finish. I asked the same question earlier too.
Yes, we at
So
NICVD,
what we
have
do is we
done-
just advance this
Okay, let
balloon
them finish.
across the septum.
Sir, if
to
I
seal
can
the hole
respond
and
to
we-
the question of PTNC with a clot in LA.
Sir Suhail, just let them finish and then we'll discuss because they are talking and it becomes difficult.
We will answer that afterwards,
Yeah,
sir.
sure.
Fine, thank you very much.
Okay,
So,
Mohsin, thank you
there is
so
no
much. A
diagnostic
great case.
puncture. Sir, thank you very much.
So this question was discussed before. I was talking about the LA appendage clot, LA clot, and NICVD had some experience, and we'll ask your experience also. So, Naveed, what precautions do you take, or would you consider doing it?
Yes, at the background is that we had some very high-risk patients who ended up with the LA thrombus, and we had to do them in any case.
So you LA thrombus or LA appendage thrombus?
LA appendage thrombus.
LA appendage.
Yes.
But you would not do if it is LA thrombus, obviously.
Yes, yes, definitely.
Okay.
Because we classify thrombus in different grades, and if the thrombus is at the tip of the appendage, there are studies in the world that they have been doing these procedures, but usually we don't do these procedures. But we were stuck with around 7 cases, and they like pregnant with pressure area 0.6, PA pressure 60, 6-month pregnant with functional class 3, 4, and she's not able to tolerate a pregnancy. And similarly, a patient with stroke, a patient with PV bleed continuously. So what we do is that, and another thing is that we had this IRV just recently done. Unfortunately, we have got our director as an interventionist, so we got this thing with some force, that we want to do these procedures because the stake is that because of the more imaging, because of the more people trained in imaging and more sophisticated equipment, we are picking up more thrombus. We usually used to miss those cases, and we used to go through with the PTMC with these cases. So we are now rejecting more. So that's why we found out that we do TE and we reject 10 cases in a day. And we say that they cannot go for a PTMC. So in those patients, especially those high risk, we usually do PTMC, but fortunately we have got this stroke program. So our IIB was really strict on it. So we said that our stroke people will be at the back and we will be doing high risk procedures. And usually we use puncture higher, not the lower one.
Puncture higher because Mohsen was saying actually puncture lower.
The thing is that when you puncture higher, you need to know that when you are going for LA appendage closure, what do? You puncture lower.
No.
It means that your system will go directly and land into LA appendage. So when you puncture lower, your system is prone to go directly and land into your wire will go directly and land into the appendage. So there are more chances that you will dislodge the thrombus. So usually we try to puncture higher, and like Dr. Mohsen just demonstrated, usually we take the wire in and then take the system and drop it down. But like in this case also Dr. Mohsen did, they rolled up the balloon and the tip was directed downwards and they pulled up the balloon. So in this case, the balloon came from the down and it dropped into the LV from the lower position, and there were no chances in going into it. There is another technique defined by the Manjunath and Indians that they usually cross with the wire and then they track the balloon over the wire. But our stance was that when you are inside the LV, you produce more arrhythmias, VT, VFib, and a lot of things. And these things a lot by themselves, they are at high risk of dislodging thrombus. So our own cases, in these all 7 cases, we defined this technique that we roll up the balloon to keep the tip downward towards the LA lower edge, and then pull up the balloon instead of keeping the balloon at the height and then dropping it down. So we have been successful, no history of stroke, and we have got this IRB done, so we'll be doing these cases on regular basis, but we have got this strict committee who will go to scrutinize this case.
It was a great case from Mohsen, wonderful case. Just another point that we size the balloon based on height, and that's what we work out with the Enoy. But something I learned from the pediatric guys that they measure the mitral annulus also. So sometimes your balloon is not opening the valve and you want to upsize, let's say the calculated size is 26 and it's not opening, you want to go to 28. So if the annulus is large, you can go 26. So, that's something which we cardiologists...
One of the question actually was earlier that how high or how much stretch you can do with the balloon.
Ji, sir. Sir, let me finish, फिर आप करते रहिएगा. Give me time.
Okay.
तो measure. ये देखो ये क्या तरीका है. जैसे चल पड़े. Let's measure. मैंने सुन लिया, देख लिया. Okay. दूसरा, I was in a session about 10 years ago in Singapore line, where there was discussion on this very thing, and there was a Chinese, a Vietnamese, an Indian, and an American and a European, and they talked about clot. Okay, somebody said if it's in the LA you can avoid it, stay whichever way, don't go into the LA appendage. And they all discussed, and the Chinese said, okay, you do this. Even Chinese failed. Then the American got up and he said, why bother? Isn't there other ways of doing it? I mean, there's a surgical case. If suppose she gets a CVA, who's going to litigations? So it's all about what kind of litigation are you likely to expect? If it happens unexpectedly, of course, it is an accident. But if you do it willfully and there's an embolization, then who will be responsible for this? You'll have to have Asim Javed standing next to you with his aspiration. Yeah.
So you wouldn't do it? That's what you're saying?
Unless there's a very compelling reason, like, for whatever reason.
Ashir, मैं एक जरा छोटी सी एक बात different perspective से बात करना चाहता हूँ. You see, in '96 when I came back, I think only Shah Zaman was doing PTMCs and he was doing it quite high volume, but he was in a tertiary hospital, and I went to an AFIC and उधर ये लोग कर रहे थे. Everyone was using reused INOI. फिर हम वापस जब NICVD में आए तो उधर फिर डबल ट्रैक और वो जो दूसरी डिवाइस होती थी मेटल, we never had an infection. They were all reusing. Cost at the moment is 4 लाख रुपए for a PTMC और वॉल्यूम है. मैं ये पूछना चाह रहा हूँ जो एक्सपीरियंस लोग हैं कि व्हाट्स द हार्म इन यूजिंग, अगर डबल ट्रैक कर रहे हैं चलें इसमें तो मैश होता है, लेकिन वहाँ तो वो मैश कर रहे थे. इन देयर एक्सपीरियंस क्यानी साहब थे, ये सारे सीनियर लोग जो थे उस वक्त, इनके क्या इन्फेक्शन होते हैं या सिर्फ हमने देखे वजह की वजह से अब हम वी आर डूइंग यूज? आई मीन नाउ दे आर यूजिंग.
Are you talking about the reuse one or the?
Yes, I'm saying that why have we abandoned reused balloon when there were no infections happening, or were they happening?
Yeah, I can tell you our experience. Again, we have a clear-cut policy for how to use it, if we reuse it, and we get a consent for the patient and tell everything, all the risk and everything. We sparingly do use it. But we haven't, at least I can tell you from our experience, we haven't seen that.
तो फिर अगर infections नहीं हो रहे और इतने सालों से नहीं हो रहे, 30 साल से, तो why are we just, for what reasons
have we? I think that policy needs to come up, and that's what I'm working on.
मैं पूछना चाह रहा हूँ ना, why are we using it for 4 lakh rupees?
I think everyone is scared of.
I will just answer one.
I'll answer it partially. I mean, we started doing PTMC at Punjab Institute of Cardiology in. We started Mayo Hospital in early 90s, and Dr. Inoy, he himself came and he performed the initial about 15 odd cases, and he used to do septal puncture with a right atrial angiogram. So he'd do the right atrial angio, then he'd follow it in the levo phase, and he would freeze both images on the screen and mark it on the screen and do the septal puncture. So that is how he described it. And there was no T, no echo, nothing.
Sure.
Now the other thing is that, I mean, as Dr. Nadeem Rizvi says, we used to reuse. I mean, I remember one balloon, we used it 15 times.
Wow.
But the material was different. Now later on, the company, they changed the material, and on the second or third time, the mesh would rupture. So you can't reuse it as much, but I agree that it's not something which should be done, because it cannot be cleaned properly.
Actually, no, there is a lot of, because I'm working on the document for reuse, and I have reviewed a lot of literature on that. A lot of places are India, it's very
they reuse a lot.
And there are studies that have shown no harm in it. And we are working on that, producing our own document, inshallah. So
I mean, there is just one point which I wanted to make regarding the, the last case. When you enter the LV with the Inoy balloon, and you inflate the distal half of the balloon, at that point it is very important to see whether you are coaxial or not. So even if there is a slight dent, Dr. Sir will bear me out, it means that you are stuck between somewhere between the cordae and the muscles.
Yes,
so if you inflate, then you are going to have horrific MR. So that is an extremely important precaution, and not to hurry. And not to pull and just inflate it.
I think what we do is inflate.
Can I make a comment?
Sir, we have to. I'm sorry. Move on.
सर जैसे बंदे को ऐड ऑन करना तो बहुत बड़ा तमगा होता है कि वो जो आप बात कर रहे हैं ना, जब आप पिगटेल डालते हैं ना एलवी के अंदर फॉर प्रेशर, उसको वही रहने दे. ड्यूरिंग इन्फ्लेशन का आप चेक करेंगे ना, तो यू नो एग्जैक्टली वेयर योर बलून इज इन्फ्लेटिंग, और दाएं है बाएं है, जिसको अब जैसे इंजेक्ट हुआ था ना इसके अंदर,
जी हुआ था, वो दिखा दिया
तो
उन्होंने।
यू नो इट इज सच अ रिलायबल, सेफ एंड ऑल सिंपल वे कि आप सिर्फ 20 cc से इंजेक्शन करना है एंड यू नो एग्जैक्टली वे यू आर, तो आपका वो जो है ना कि कॉर्डी में ना फंसाओ, बलून के नीचे सब वाल्वुलर ना इन्फ्लेशन हो जाए, ये सारी चीजें ठीक हो जाती हैं।
सर वेट, ओके सर, क्विक कमेंट
मेरा जो थोड़ा सा तजुर्बा है,
थोड़ा करीब
उसमें जो
करीब कर लेना, माइक
जो लास्ट कमेंट जो दिया था नदीम याद साहब ने, इसमें जो चीज़ है बुनियादी बेसिक चीज़ है जो कि अभी हमारे नए लोग जो है नहीं कर रहे, बेस टू एपेक्स को बलून को रखना है। वो मिड में ही बलून को छोड़ के इन्फ्लेट कर देते हैं और फिर पोल करते हैं। तो जब भी हो, जैसे मोहसिन ने किया, बिल्कुल सही किया है कि एपेक्स पे लेके, तो बेस टू एपेक्स पूरी अलाइनमेंट करके
मूवमेंट।
नंबर सेकंड कमेंट रिगार्डिंग एले थ्रोम्बस का है, कुछ थोड़ा बहुत तजुर्बा है, तो उसमें एक इंडिकेशन नवेद मिस कर गए कि पीए प्रेशर 100+ वाले जो सर्जिकल रिफ्यूजल होते थे तो उनकी मजबूरी होती थी, उनको भी हम कर लेते थे। तीसरे जो पंक्चर की जहाँ तक बात है, एले थ्रोम्बस अपेंडेज में अगर आप कमिट करते हैं तो उसमें कुंडी साहब हमारे बताते थे कि आपने रुकू में रखना है, रुकू में ऐसा रखना है, थोड़ा सा हायर पंक्चर रखेंगे तो बलून रुकू में होगा और सीधे जो है ना एले टू एपेक्स जाएगा।
Quick one comment, we have to finish actually.
Thank you very much. Yesterday I had a talk on PTMC about the balloon sizing and imaging for PTMC. उसमें इम्पॉर्टेंट बात ये है कि इमेजिंग की जो है वो खासकर TE, this is mandatory for each and every patient for PTMC because it gives you the well morphology and other information. Sometimes we underestimate the mitral regurg and you cannot see the appendage clot on thoracic. So this is important, so you have to quantify this. But the important information on esophageal liquor is that it also gives you very good information about the interatrial septum. For example, if your anterior atrial septum is very thick, reason may be previous fibrosis or repeat PTMC or thoracic radiation, then you have to change your plan. You will not be able, or if it is lipomatous infiltration of the interatrial septum, then it is very difficult to puncture with artery. Then you have to take the help of EP people, and you have to puncture the septum with the radio frequency equipment. And another important thing is that when you do PTMC, so intraoperatively transthoracic echo, you have to see whether your commissure has split away or not. If it is not split away, the patient will come with restenosis again. Okay. So on both ends, if you have split your commissure, then the result will be good. And on the same time, you will prevent excessive mitral regurgitation as well.
Thank you so much. I think quick, very quick. We are getting late.
Just there were two questions regarding the LA thrombus, especially in the PIC, Peshawar Institute of Cardiology. We have very strict MDT system. So 2 surgeons and 2 cardiologists are there whenever we are discussing any patient, severe mitral stenosis patient have the left atrial appendage pungent, the thrombus. We have done a few cases, and especially as Dr. Naveed Saab mentioned, that we just try to do in the usual fashion, especially via the loopy wire, we try to cross that. And we are almost always doing this also with the TE guidance. The second question regarding
so every patient you're doing TE guidance?
Yeah, TE plus the fluoroscopic guidance, especially the patient with the LA thrombus. One patient, even with the LA thrombus we have done at that time, we were kind enough that, Asim Jalil Saab was kind enough that he was there in the Peshawar Institute.
Maybe we should do a multi-center instead of only your center.
Yeah, there was LA thrombus especially on the roof, and we have all the stroke gadgetry
thank
there.
You. We have to move on. Last comment.
Just about the well area, there is recently 70 patients done at Europe in fluorescence, and we also done a couple of the patients like a Apollo study we did, that those patients who are really pliable valve, you can augment a bit the balloon like say 0.5 millimeter, one thing. Another thing about the measurement is not only this surface area, it's a 3D echo where you see the intracommissure distance. And I was looking, some of the patients, they need 30 balloon. Then I asked, they say that yes, we have 30, but I just want a question just for this, that we should give the best result to our patient. How many of us has taken a 30 balloon? Just a question.
So Naveed, you want to?
Okay, so we never used a 30 balloon.
So
and one thing is that we need to know that this is more of a palliative procedure. We need to understand this, that we want to give few years because this is just the ballooning. We are not reducing the procedure, the disease itself. And we never go at NICVD and other thing, we never go oversize. But instead, what we are doing in patients with more than 8 Wilkins score, we are doing PTMC regularly in calcified and more than 8 Wilkins score. But our strategy is to go undersize, open up the balloon, see the gradients, and then serial gradually stretching of the balloon, and then stretch it to the extent whatever it has. And this has been published in JAC intervention. Our thrombus cases have also been published in JAC, and we are getting good results with it. We are getting area of more than 1.5.
This was just innovation. So this is just innovation about it.
Bashir
Innovation about the mitral valve, balloon valvuloplasty. What I'm sharing, innovation.
So his initial question was that if somebody is like it, 26 is the maximum based on the body surface area,
Yes,
can you
we'll
go
to
beyond that?
126. No.
That's the maximum.
Bashir sir, एक comment.
Sir, please, we
Just
have to
last
stop.
comment.
It looks like next time we have to give more time to PTMC than to because that's the more common procedure. But believe me, when I was making the program, when I said we need to do this, and they said no, we don't need to because we should time to others. But next time we'll do more to PTMC.
साहब के जो इंटर कमिश्नर डिस्टेंस है ना, उसकी एक स्टडी हम कंडक्ट कर रहे हैं. उसमें जो रेगुलर स्कोरिंग है विल्किंस, उसको कंपेयर कर रहे हैं विद इंटर कमिश्नर डिस्टेंस. ये दोनों चीजें प्लस जो हम बलून यूज कर रहे हैं, तो ये तकरीबन 200 केसेस हो गए, हमारे कंप्लीट हो जाएं, फिर हम एनालाइज करके
सर मैं रिक्वेस्ट करूंगा कि वी शुड स्टार्ट वर्किंग ऑन मल्टी सेंटर ट्रायल्स. बाकी लोग भी कर रहे हैं, अगर मिलके करें और वो ज्यादा उसकी वैल्यू होती है. जैसे माशाल्लाह इतना अच्छा आप लोगों का ट्रायल अभी एसीसी में प्रेजेंट हुआ है, और अगर ये मल्टी सेंटर हो जाता तो इसकी मतलब वैल्यू वुड हैव बीन मच मोर. तो इस तरह के जो भी स्टडीज हैं, इफ वी वर्क टुगेदर, बिकॉज जैसे पीआईसी, लेडी राइडिंग और बाकी जगहों पे भी हो रही हैं, तो जो भी स्टडी इस तरह की करते हैं, इफ वी डू कंबाइंड, आई थिंक उससे पेशेंट्स भी जल्दी हो जाएंगे एंड वी विल हैव अ मच मोर वैल्यू एंड रिलायबिलिटी एज वेल. So I think we have to move on. I'm sorry, there are a lot of comments, but the time is short. People have flights also. So we are going to do one case presentation on complication on PTMC, and then we'll move on to the closing ceremony. So please, who is doing that? PTMC के लिए कौन था? अब क्या? Yeah, go ahead, please. Navid.
Bismillahirrahmanirrahim. Assalamu alaikum. I'll try to be quick, and इसमें शायद बहुत सारी चीज़ें जो हमने की वो सामने आ जाए. Okay. So that's what we tell to our fellows. When they come to us, we have got 50 fellows coming in, intervention fellows, and then, but we add up one thing with this. Though don't try to make your own bad decisions, learn from others' bad decisions. So this is a good thing, that when you are sharing a complication case, so we need to learn from our bad decisions, and then we share with this one. So we had this patient, 64-year-old female, morbid obese with BMI of 41, height of 159 centimeter, severe symptomatic MS with moderate AS. And she was turned down from the surgery because initially she was enrolled for a DVR, but considering her obesity and frailty, they decided that we will just go for PTMC and open up the mitral valve so that she can get a few more years. And along with this one, PA pressure was 60. That was again another issue with the surgery. So without any further delay, I'll show you some. There was some calcium nodule, and this answers some of the questions of this one, that usually at NICVD we have our strategy that in these kind of patients we try to go undersize. You see calcium, you don't want any complication in these patients. You want to give them with this 0.7 area. If it reaches to 1.3, 1.5, that's okay with us. So she will get few more years with this, and she's already 64, 65. So there was some mild MR, and we proceeded for the procedure. Because of the morbid obesity, the imaging was not very good, and the images were blurred. And as usual, we had some problem with puncturing. there was an not accurate point puncture, but finally we were able to. There were 2-3 attempts of trying to go the puncture. When we punctured, went into LA, positioned towards the mitral valve, and then finally we thought that we have crossed, and this was the position of the NOA balloon. And that's what Dr. Tai Sagir was just saying. This was our training, that we were not able to reach to the apex. And there was another problem at this point of time. Patients' pressures dropped. And this is not the first time we had this kind of problem. We have another case before, but whenever we wanted to try to cross the mitral valve, anatomically, fluoroscopically, because we are not going under TE guidance, it was looking good. The position was looking good, but we were not able to reach to the mitral, the apex, and the pressures dropped. So we said, where we are. We had another case before with us. In this patient, ये रन कैसे हो? What is this structure? Are we in the LA? We are not in the LA. This was another case. This is not this case. This was another case. We had a similar problem. So we injected, and to find out that whenever we are trying to cross the mitral valve, we go into some other structure and the pressures drop. So, sorry? It's a vein. It's a vein. But that was the question in our mind, that if you obstruct one pulmonary vein, why the pressures are dropping? So is it some anomalous coronary vein draining into LA? We didn't know. So in this patient also, we decided to inject and see where we are. And we were in some venous structure. The patient's pressures dropped. And we then injected and found out that we are definitely in LA. But this is some sort of left lower pulmonary vein. And we are just continuously going in that vein. So we know that the usual technique of going from pulmonary vein into the mitral valve is you pull back and rotate anti-clock, because we have learned this from our EP guys. They say that if you are in the appendage, just pull back for ASD and pull back and rotate clockwise, you will go into pulmonary vein. So if you want to go from pulmonary vein towards the mitral valve, pull back and anti-clock. So we pulled back and crossed the mitral valve. And now we were comfortable. And at this point, things look good. We were happy. Mashallah, procedure ho gaya. But another thing which we noted at this point of time, and you might have noted, the patient's pressures didn't come up. पहले हम सोच रहे थे कि हमने वो वेन को इतना छेड़ा है, सारा कुछ किया है, तो प्रेशर ड्रॉप हुए हैं. अभी भी प्रेशर वापस नहीं आ रहे. So we found out, if you can see the cardiac shadow, the patient has developed tamponade. There is some effusion there, and now this thing comes up. Now, how to react on it? This patient is high risk. You have already turned down from the surgeon. You have opened up the mitral valve. Then what to do next? You want to send him for surgery, send her for surgery, and they will do AVR plus. So it's our institutional. We started, okay, जब तक सोच रहे हैं पहले तो इसको तो drain करें. We started pericardiocentesis and autotransfusion, and then what to do now? So morbid obese, high risk, decided to go conservative. How to manage a cardiac perforation conservatively? This is the thing we have learned from our TAVI practices, and that's what I want to share. not to send her for surgery, the conservative non-surgical management of cardiac perforation. The first thing is that anticipate site of perforation. किया क्या है? हमसे पूछते हैं बॉस आगे किया क्या था ये तो बताओ पहले. तो अगर तो ये हुआ है. अगर तो if you have perforated LV, then just stop and go home and then बाकी दुआ करें, बाकी या सर्जन से बात करें. But if it is not LV, our practice is that immediate pericardiocensitis, auto-transfuse till the pressures come up. Now that the auto-transfusion process is going on, and open up the mitral valve. This was debated in our committee also. जी अभी तो surgery पे भेजना ही है, फिर आप open mitral valve क्यों open कर रहे हैं? But we know that you will reduce the burden on the surgeon also. The surgeon कहता है कि भाई खुदा का शुक्र है जी अभी मुझे 2 काम नहीं करने, मुझे जाना है सिर्फ साइट सील करनी है और बाहर आ जाना है. Instead of doing a emergency MVR. So this was another case. You will not ask me आप लोग कितनी perforation करते हैं. ये एक और case था जिसके अंदर we came to know about the perforation before we could open up the mitral valve. In our case, which I am presenting, we came to know about perforation after we have already opened up the mitral valve. But in this patient, we were in the LA, we noted the perfusion, but we proceeded, we were doing auto-perfusion, and we opened up the mitral valve. Because the concept behind this one is that when you open up the mitral valve, you reduce the chamber pressure. Because if you have perforated LA, the LA pressure will reduce after opening the mitral valve. If you have perforated RV, the RV pressure will reduce after opening the mitral valve. So the rate of accumulation will reduce. And at the same time, this was the thing which we learned from our TAVI experience, because we used to had some TPM lead perforation after the TAVI. And we decided to manage those patients conservatively. How to do this one? We keep, when the pressures come up, we have opened up the mitral valve, you keep some fluid inside the pericardium. And with the concept that LA pressure have reduced, when you keep some fluid, mild effusion inside the pericardium, you try to equalize the pressures. And at the same time, this was the thing, keep some fluid in the pericardium, and usually it's around 4 to 5 millimeter of effusion. Don't suck it out, because when you keep it negative, the more fluid will keep on coming into the pericardium. So you suck more, you will get more. So if you keep some fluid inside the pericardium, the LA pressure, you have already opened up the mitral valve, the LA pressures have reduced. Observe the rate of reaccumulation. Usually after half an hour or 1 hour, usually it stops accumulating if it is a small perforation. वही बात है कि आपने किया क्या है. If you have done a large laceration, then it will keep on coming, then you have to send the patient for the surgery. But if it stops and the rate of accumulation, and you don't need further draining, you are keeping some fluid, mild effusion inside the pericardium, and the LA pressures have reduced, then you may consider heparin reversal. But another point in this one is that when you reverse heparin, usually clots develop inside the pigtail and inside your sheet, and you have got false impression कि जी अब fluid नहीं आ रहा. वो आपकी sheet clot हो गई होती है, अंदर accumulation हो रही होती है. तो इसलिए protamine is kind of a double-edged sword. But still, you can give protamine right now and observe. And now, you can bring the patient out after usually half an hour observation, no further accumulation, patient is stable. In this patient, that's the thing happened. And we brought the patient out with a stick hemodynamic and serial echo observation, and drain only if sign of tamponade develop. Bear with mild effusion, because this effusion is trying to equalize this LA pressure which you have punctured or you have lacerated. So LA pressures have reduced, the pericardium has got some fluid. These are trying to equalize those pressures and sealing this one to try to go for a stick hemodynamic observation and drain only. आपको fellow को कहना पड़ता है, हम कहते हैं भाई इसको रात को फिर suck नहीं करना. अनलेस यू गेट ये प्रेशर ड्रॉप कर रहे हैं या एको के ऊपर टैम्पोनेट के साइन नजर आए. अगर माइल्ड डिफ्यूजन है, जस्ट सिट ऑन इट. And usually we do it for 1 hourly echo initially, and then we go for a 2-hour echo with a stick dynamic observation and keep pigtail for next 72 hours. If 72 hours are okay, then you just drain the whole thing. Post PTMC echo was okay. So in our case, mitral valve area came out as 1.6. Patient went home after 1 week. Thank you.
Thank you very much, Naveed. Great case and great outcome. So I think we are getting a little time short, so we are going to move on to the next session. I'll hand over to Jabbar, who is going to take over the next session regarding interesting cases.
Hello. Just one question at the last regarding this perforation site. I just want to ask one question regarding the heparin reversal. You said even after the perforation, you're going to give the protamine. So do you have any experience? You have the gadgets inside, intravascular, and you're just giving the protamine, and there are high chances of gadgets occlusion with the thrombus. So because the book says you have to move out all the things first, and then have to go for the protamine. So what do you have experience regarding
Yes, that's
this?
what we do. That's why we say that you finish up your procedure. Don't wait for कि जी a mitral valve खोले या ना खोले. जैसे as soon as you know that you have got this effusion, at the time when you are doing auto transfusion, complete your procedure so that you can take your all gadgets out. Yes, we advocate that don't keep any wire inside. When you if your wire is inside, don't give protamine.
And at the end, protamine has to be
protamine at the end, because usually we try not to give protamine. But if this thing is accumulating, because I've told you before that once you give protamine, another thing is that your sheets start getting clots. Your pigtail gets clot and patient develops signs of tamponade. और आप बाहर कह रहे थे नहीं अब तो कुछ नहीं आ रहा, लेकिन वो होता ही है कि pigtail clot हो गया होता है, अंदर diffusion develop हो रही होती. तो इसलिए we say that protamine we give at the end and try to avoid protamine so that you can give get these things.
Thank you.
Thank you very much, Dr. Naveed. So we have come to the last sessions of this Pakistan Live 2025. It consists of two portions. The first the fellow will be presenting the 4 best cases, and in the second part there will be a speech from the president and there will be award distribution ceremony. So first of all, I would request the chairperson for the session to come on the podium, to take their chairs. The first is Professor Zubair Akram. General Suhail Aziz. Professor Tahir Saghir, Suhail Salimi, Professor Muhammad Ishaq, please take your chairs. Professor Bashir Aneeb, Professor Nadeem Rizvi, Professor Noman Nasir, and General Azhar Kiani. So they all want to stay on their own seats. So the first, the cases, 4 cases will be presenting. It will be in reverse order. Please, the presenter should remind that they have only 5 minutes. The first presenter in reverse order is Dr. Ehsan from PIC, Peshawar.
Bismillahirrahmanirrahim. Good morning. My name is Dr. Ehsan from PIC Peshawar. In today's cath lab nightmare sessions, we are going to present our case of a young patient having a rare lethal complications, which was tackled nicely. So, moving on to the case summary, there's a 34-year-old young patient who had severe coarctation of aorta and concomitant severe AS. Case was discussed in MDT and was decided to go for coarctation stenting first and then followed by SAVR. So the patient was shifted to the cath lab, and you can appreciate the significant coarctation of aorta on fluoroscopically, which was stented with cover stent 18 by 45 successfully without any significant residual gradients. But after coarctation stenting, the issue was the patient get unstabilized and went into cardiogenic shock, had flash pulmonary edema, and patient had a cardiac arrest. CPR was done. The patient was resuscitated and then shifted to the ICU. But in ICU, the young patient was deteriorating further, which is evident from the flash pulmonary edema on the X-ray chest. What should we do for this young, miserable, poor guy who is in a life and death situation right now? So the options could be SAVR, BAV, ECMO, and then SAVR. And they also involved this time the structural heart team. And as the cardiac surgeon declared the patient unfit for the surgery right now because of the cardiogenic shock and multi-organ failure. So we gave the options of either BAV followed by SAVR and BAV and TAVI as a bailout procedure if the patient condition further deteriorates. So the patient was shifted back. But unfortunately, we didn't have a CT TAVI protocol. We usually do a CT TAVI, but we didn't have that. So we analyzed the CT TAVI done on the Radiant, and which showed that the patient was having bicuspid aortic wall with the severe classification 0 with moderate calcification, good coronary heights, and the wall was decided 34 evolute. So the patient was shifted back to the cath lab for the BAV, and we intentionally performed BAV with a smaller balloon to avoid any further complications like torrential AR or further consequences. But unfortunately, the poor guy on high inotropic support went again into cardiac arrest, and so as the structural heart team was in the cath lab, they already prepped and checked and loaded the wall and checked the wall. So it was decided to proceed with the TAVI wall, and within thought to explant the wall later on follow-up if the patient survives. So you can appreciate that the TAVI wall was nicely implanted to a femoral root when post-dilated with the 25 balloon without no significant AI, and in a while the patient condition stabilized a bit with decreased inotropic support. We shifted the patient back to the ICU, and where the patient condition further improved, which is evident even from the chest X-ray. This was the chest X-ray before TAVI. And after a few hours TAVI, you can appreciate a significant improvement in the pulmonary edema. And on the next day, even a more significant improvement. And the patient inotropic support was tapered off, and patient was extubated in a couple of days. So the take-home message is heart team approach and better pre-procedure planning leads to better outcome. Before, be aware of TAVI acute complications and management. There should always be a plan B. Complex and high-risk cases should be performed in a well-equipped and appropriately trained facility. And as the PIC unit has already trained their fellows and cath lab staff to prepare and load the wall, which was an opportunity that was brought in, and the patient was rescued from the lethal complication. Thank you so much. Thank you.
Thank you, Dr. Ehsan. It was really a great case and a great save, and you did it in time. Now I request Dr. Rahman, he's again from PIC Peshawar, to present his case.
Assalamu alaikum. My name is Dr. Rahmanullah. I am a fellow of Interventional Cardiology at Peshawar Institute of Cardiology. So today I will be talking about what and how important was the missing piece of a puzzle in our case. So let's start. We had a 51-year-old female who presented to us with shortness of breath, NYHA class 3 and palpitations. She had a history of severe mitral stenosis, transthoracic echo confirmed the same, and there was a large interatrial septal aneurysm. The TE images showed a very favorable mitral valve anatomy, a very large interatrial septal aneurysm, no LA appendage clot, a large LA, and no significant MR. So it was discussed and decided that we are going for PTMC, keeping in view that there will be an increased risk of perforation because of the very large intra-atrial septal aneurysm. So we started from the conventional approach, right femoral vein for the transeptal puncture. But no, the twist came when the usual fluoroscopic anatomy was not observed by the operator. Neither he was having the feel of the septum. So after trying multiple times and in different views, he was clever enough to decide it that we are going to postpone the procedure and do it the next day with TE guidance. So the patient, again, the next day was brought in the cath lab, GA given, and TE guidance was taken. Again, even unfortunately, the TE was not helping us a lot because we were not able to appreciate the Mullen sheath inside the RA on TE. While we were in our presumed RA, in the fluoroscopy, we injected some saline and it was coming from the SVC. We were not observing it inside the RA. Multiple venograms were taken at different levels, but at this stage, nothing was helpful. We were in dire situation. We were suspecting something, that there is something wrong, but we were not getting to it. So we kept on, and finally, we got a silver lining from the guide wire. So the guide wire basically helped us in solving us our puzzle. It followed a very unusual path from the RA to some bypass channel and then SVC and finally into the to the RA. From the IVC through some bypass channel into the SVC and then RA. We immediately confirmed it in the fluoroscopy, which showed that yes, there is a bypass channel between the IVC and the SVC, and this was actually an interrupted IVC, a very rare anomaly, and thanks God, a very good save, because a puncture at that time would have ended in a dreadful complication. This is a diagram to better illustrate what we were going through. So this is the IVC, a zygous continuation of the IVC, and this is the SVC. And this was the direction of blood flow and also of our wire. So now the puzzle has been solved somewhat, and we decided that the only option left is to shift to the internal jugular axis. So we shifted to internal jugular axis and made the transeptal puncture with the Mullen sheath and the broken brow. A step we were considering very hard was in fact very easy because this was in the thicker part of the septum. So after the septal puncture, our life again was not easy. We were having difficulty in passing the NO balloon from across the septum and the mitral valve. So after trying for a few times, we decided that we need to upgrade our armor and take the veno-arterial railing for stable support of the So we took an extended Chiroma wire and passed it from RA to LA, then LV aorta, and from the subclavian artery, we snared it and pulled it out from the right femoral artery. A stable through and through rail created, and this was enough. There was enough support that the NO balloon passed into the LV. Now we have our NO balloon inside the LV. And it was confirmed on the TE, and RAO caudal view was taken. The wire was pulled out, the balloon was set free, it was aligned along the cardiac axis and inflated. At this place, I would stress that RAO caudal view was taken purposefully because of the Nicola Piazza's work on the S-curves of the peppery muscles, in which the RAO caudal view shows that the peppery muscles get overlapped and shortened, and if the balloon is in the above part, you can easily pull it and inflate it. So we had a successful PTMC with a mitral valve area of 1.9 centimeters square and no significant MR. These are the echo images of the patient. So this was a very rare anomaly taken, handled very tactfully by our team. And the take-home messages are that anatomical variations are rare, but they do occur, and that should be the anatomy should always be clarified. We should be adapting our procedures to get some innovative procedures like railing and snaring. And the last but not the least thing is that there should always be a multidisciplinary approach to tackle such rare and tough anatomical variations to ensure procedural success and patient safety. So thank you all. I hope you people enjoyed it.
Thank you, Dr. Rahman. It was a great innovation and again a great save. Now I request Dr. Sajid. Probably he is not around, he was not feeling well, so his case will be presented by Professor Muzaffar Ali.
So thank you very much, Dr. Jabbar. I congratulate the whole PSAC team for holding a beautiful event, in fact. So here is our case scenario as a 60 years old hypertensive with acute STEMI, anterior STEMI, presented in ER, and our primary team that time decided to go for the primary PCI. Here is the angiogram, and look at the LAD is totally occluded, and the other vessels are RCA, normal disease, normal looking vessel. So that time the primary operator tried to open the LAD, and there was a bit difficulty in wiring, but somehow he was able to put the wire distally, and he put a balloon, although it was small balloon, 2 of 15, and look what is happening. So there was a perforation, and as a knee jerk reflex, he inflated a balloon in the proximal vessel with the intention to obliterate the perforation, but there was no luck. So he also tried a macro balloon, putting a macro catheter there and putting a coil embolization. There are several ways, the coil embolization or clotted blood or gel foam or fat, but clotted blood was available that time, but there was no luck. He also put a negative section through the wedged macro catheter in a view to obliterate this small vessel, but there was no luck. So at this time he called us. So we reached there, we analyzed the situation. So there is a septal perforation. Initially he thought it to be LAD, but in fact it was the septal, big septal branch. LAD is still occluded. So now we have two challenges, two troubles at the same time. So we have to open the culprit vessel, LAD is still occluded, and there is septal perforation. It is one of the mild, it was ILS type 3 perforation, and there were two jets, medially and laterally. So we initially wired the LAD, we were successful in no time and dilate carefully, and we achieved a TME2 flow in distal LAD. So now there were option of what to do with this perforation. So historically septal perforation initially tolerated well, but you know hours after the initial procedure there may be cardiac tamponade. So it was type 2 LS perforation, and we did echocardiography. Echocardiography augmented our thought process. So there was mild pericardial effusion in background of borderline hemodynamics. So we put a metallic disc across that very perforated branch in a view to open the vessel and divert some flow into LAD, and also to have a curtailed flow across that very perforated septum. But there was still extravasation. There was a TME3 flow in distal LAD. We put another 2.5 15 disc, metallic disc inside the very first implanted disc. So, but still there was extravasation. So at this time we planned to put a cover stand. Luckily we were having PK Papyrus, and Bilal Saab is always very kind. He helped us to rescue this situation. And look, when we put this cover stand, there was all complete sealing of the cap. So we did echocardiography, mild pericardial effusion. The patient was remained stable 48 hours after the procedure, and he was discharged. And first follow-up, he is doing very well, and without symptom, we have a planning to do reloc angiogram also. There are several lessons. Whenever complication can happen, but hold on your nerves and be cool and accept the risk and realities. So don't be aggressive, as our senior mentor often do teach us, and in the interventional cardiology do not push. So always beware of your wire position constantly and carefully. So septal perforation were tolerated initially well, but may later in late hour present with the tamponade, so try to fix it earlier. So there are several ways of treating the small vessel perforation or collateral damage. So, but in the face of failure of the coil embolization, the putting a cover stent across that very perforated branch become very handy, as was in our scenario. Thank you very much indeed.
Thank you very much, Professor Muzaffar. It was a great case and a great save. And now we have come to the final case, and it will be presented by Dr. Aspangyar, Lady Reading Hospital, Peshawar.
Good morning to all of you. I'm Dr. Asfandiar, and I'm an intervention cardiology fellow at Lady Reading Hospital, Peshawar. Thank you, Park Life, for giving me this opportunity. Today I'll be talking about navigating the risk. There was this complication, and we'll be talking about that complication as well. So I have got no disclosure. And this is the story of a 70-year-old lady who was diabetic, who was hypertensive, and who was having this osteoarthritis, due to which she was function class 2. She presented to us with extensive anterior wall MI that was probably 1 month back, and at that time she was having chest pain, and then she was managed conservatively. At this time, when she presented, we noted that she had developed this complication, which is the apical VSR, although the symptoms were only shortness of breath and there was no chest pain. So we sent the patient for surgical repair of the apical VSR, but that was turned down by the surgical team due to her high risk of perioperative MACE. So then again she presented to us for this transcatheter apical VSR repair. On presentation, she was vitally stable, she was awake, alert, and oriented, and obviously there was this loud pan-systolic murmur all over the pericardium. The echo shows an ejection fraction of 35%. The apex, intraventricular septum, and interior wall were akinetic, and there were no abnormality noted on the mitral and the aortic wall. So this is the first picture. This is an apical 4-chamber view showing that apical VSR, and the other one is the still image which showing the size of that VSR. Here it was 18 millimeter. And now this is an LV angiogram showing the apical VSR, and the other slide is showing that we have crossed this VSR with the GBR catheter. Here the VSR measured was 20 millimeter, so a 26 millimeter septal occluded device was taken. So just after deployment of this delivery sheath, the patient got bradycardic, the patient dropped saturation, and she became hypotensive, subsequently progressing to cardiac arrest. So we initiated the CPR, and back in our mind we were thinking what might have happened. So the patient, obviously this was a panic situation. You have to think fast in this situation, and obviously when this occurred, so the primary operator was the primary operator was there, but she was joined by 3 other intervention cardiologists. They made a team, and they thought that okay, let's start with the beginning. So what we did is that we did a transthoracic echo, and that echo showed pericardial effusion with the tamponade. So obviously pericardiocentesis was initiated along with autotransfusion. The patient was intubated, and inotropic support was started, and TPM was passed as well. We contacted the surgical team, but obviously at this point of time they declined that the patient is due to the patient critical condition. So at this point, after doing these interventions, the patient was somewhat stable at this point of time. So, and the AV loop was intact, so we decided to proceed with the deployment of the device. So the device, you can clearly see over here that the device is implanted, but there was still this pericardial effusion, so we were thinking that, okay, this might not be the culprit. I mean, the culprit must be something else because the pericardial effusion is still there. So what we did is that if you can focus on this transthoracic echo image, and if you can clearly focus on the lateral side of it, you would see that there is this suspicion of LV free wall rupture. So in order to confirm that, we passed this catheter, and obviously echoed it, and later on it was confirmed that yes, that there was this LV free wall rupture. Now, in order to close that defect, we advanced the catheter, we parked this pteremo exchange length wire, and we parked this wire in the pericardial cavity. So this time we applied the retrograde approach because the antegrade approach was not feasible as the device was already there. So in the retrograde approach, we usually start from the femoral artery, we go through the descending aorta, then the ascending aorta through the aortic wall into the LV cavity. You can clearly see that the device is parked, the pteremo wire is parked in the pericardial cavity. And here, a 14-12 millimeter PDA device was taken that was successfully deployed. You can confirm this. The pericardial effusion was somewhat stabilized at this, and we shifted the patient to the CCU. So the idea behind presenting this case is that you need to recognize the complication early and you have to take swift actions. The other thing is that the role of echocardiography is very much important. I mean, there are no two ways about that. And the last, but definitely not the least, that multidisciplinary team approach is important. In time of crisis, you have to ask for help. Thank you.
Thank you, Dr. Svanjar. It was really a great save and a great case. One thing, it might be underreported in crop, but we do a lot of complication. This time we had at least 76. So maybe we are not reporting in crop, but complication is still there, and either we are not reporting it or we are not presenting. Now I would request Dr. Bashir Hanif to reflect on 2025 POC Live and give his view.
Thank you, Jabbar. I think I can take a deep breath now. My pulse has been going down day by day, and I checked my pulse today, and it was to baseline now after we finished this almost at the end of the Pakistan Live. Thank you so much. Obviously, it's not possible with all of your support, and it's not a one-person role. It's a team effort. And our team included obviously the other course directors, Tahir Sagir, Asad Khan, and I think Jabbar has done extraordinarily this time. Previously, Arslan used to do a lot of work, and Jabbar has helped me a lot, and a big hand for him. Thank you so much, Jabbar. I think there is a lot of work goes behind this, and I am not exaggerating it. It's like months of efforts and weeks of sleepless nights. It's not easy to coordinate with the people, especially international people, the timings, the live transmissions, and all that kind of a huge amount of work is involved in it, and no one person can do it. So it's not me. I know a lot of time people take my name, but I think it's everyone's efforts, and obviously the orbit plays a huge role in it, and my rest of the colleagues and all of you. Obviously, without your help, this is not possible. Pakistan Live has come a long way. All of you know, starting from 2016, when we had, I think, 1 or 2 international live cases, and there was a lot of problems. And Alhamdulillah, today, this time we had like 10 live case transmissions and almost 10 local live transmissions. Obviously, there are still some glitches which we need to improve, and hopefully with every year things are improving. And I think I can tell you, at least from the international faculty who attend Pakistan Live every year, everyone says, Alhamdulillah, this is nothing less than any of the international conferences. And I would request everyone, this year, although I request every year, but this year we have decided that we will give the certificates, CME and other certificates, after all of you fill a feedback form which will be available in a couple of days in the coming week online. So you will fill the form and you will be able to print your certificates from there as well, just like ACC. But one additional thing I want from all of you, or we want from all of you, is basically please give us suggestions to how we can improve. And obviously, the more suggestions we get, we'll try to see what we can incorporate. But definitely, your suggestions are going to be very important, and we will try to incorporate those suggestions as much as possible. Just like we just talked about that PTMC, I think it definitely needs a more time during the next Pakistan Live. And next Pakistan Live, inshallah, is going to be in Lahore, and we are thinking, and it will be finalized from April 9 to 12, inshallah. And we will start actually preparing the day it ends, and we'll be working on it. So we want all of you, request all of you to please go online, go to the website, log in, and give your feedback and get your certificates, and also give your suggestions so that we can improve further on this next year. Participation from all of you is important, and we have requested before also, but despite that, unfortunately, despite confirming with the people for the chairpersons or moderators or rest of the involvement in the meeting, unfortunately still some of the people don't show up at the last moment, or just the reason actually when we talk about that the program was not available 1 month ago, unfortunately the problem is, believe it or not, I was getting cancellation just the night before of the program, and not only one, not only two, several of them, and those who had major roles in the meeting. So this kind of things we have to stop, and we have decided this year that all those who have done this, they will not be involved in the future, and this is what we are going to do. That we are going to make a criteria, and in future those who are not showing up, if they were in the faculty or if they were chairpersons, they did not bother to, that means they are not interested, and we will not involve them in the future as well, and this is going to keep happening. So please, I think for us, we really appreciate your time and everything, but you should feel it's your meeting, you should be honored that you are called over here, so you should take the time out and decide beforehand whether you will be able to do it. Unless it's an emergency, you should make sure that you are able to come over here. So if you don't, then obviously that means you are not interested, and we are not interested as well. So please make sure that in the future you do that. And thank you once again, everyone. Really, those who came out of the city or from the city took the time. I think it's a great learning opportunity. Not only learning, but getting together, socializing, and we'll keep working on to improve it every year. And your suggestions are more than welcome. Thank you so much. And lastly, I really want to again thank GBR, because the cases, a lot of people actually kind of complain also that our case was not selected or why ours. I can tell you it was a very, very transparent process. We got like 70 or 80 submissions, and we sent all those submissions. One was a local expert and one was an international expert, and the name was hidden. No one knew who has sent this case. And there was a numbering process. We have a whole form to number how the presentation was done, what's the value of the case, what is the learning. So 1 to 10, they number these, and according to those numbers, whoever comes in the top 18, we select them. So there is no favoritism in these. So this year I would request also that you should start accumulating these cases right from tomorrow for the next year. And we have prices which will be announcing shortly, and in the future we might be sending you to conferences also. So please start accumulating cases right now and send it to us so that we can have better case presentations and also learning value as well. Thank you.
So now we have a prize distribution ceremony. It will be first to the interventional cases that were presented this morning, the 4, and there will be also a presentation to the cardiac Olympic and short tank. So first of all, I request General Suhail to come on the stage, and he will be giving the awards along with the course directors. Dr. Bashir Hanif, Dr. Tahir Sarir, and Dr. Asad Akbar. Is he around? So the first, I will call Dr. Ehsan. He stood 4th, and he will be given Rs 50,000. The second is, the third is Dr. Rahman from Peshawar Institute of Cardiology. He will be given 75,000. And the second is Dr. Sajid, but he's not around. On behalf of him, Professor Muzaffar will receive the award from General Suhail and the course directors, and it is $100,000. I hope he gave it to his fellow. And the first prize goes to Dr. Asfandiar Ali Khan. He is from Lady Reading Hospital, Peshawar. Now I request Dr.
So we had two new events this Park Live. One was Cardio Olympics, whose results were announced yesterday. It was a very exciting event, very fun event. But the Shark Tank results are yet to be announced. And we had some very interesting projects which were presented, and hopefully they'll carry on and complete the research as well, because they're going to get 50% of the prize money now and 50% after completion of the project. So third prize was to Dr. Poonam Bai from NICVD for interesting concept, prophylactic administration of vasodilators via experimental fenestrated lumen, open label work in high thrombotic lesions, a randomized controlled trial. And I would request Mr. Abdus Samad Siddiqui Saab, Director Marketing Sales from Farm Evo, who's going to bring the checks to join us on the stage as well. So, and second prize is for Dr. Michelle Zahra. She presented the technique for aortic valve crossing yesterday as well. An interesting concept again. So they're going to do a prospective multi-center study comparing procedural efficiency and clinical outcomes of a novel versus standard retrograde aortic valve access technique in TAVR. So. And winner of the Shark Tank, Dr. Jamshed Ali from Khan. His project was interesting. He's going to carry on the previous MRI project, which did not, was neutral trial with the utility of cardiac MRI in guiding aortic valve replacement in asymptomatic severe AS patients.
जो कार्डिक ओलंपिक्स में तीन लोगों ने जो जीता था फर्स्ट डॉक्टर शम्स he stood first. He's from Lady Reading Hospital, Peshawar. Dr. Asfandiar Ali Khan, he is again from Lady Reading Hospital, Peshawar, and Dr. Ijaz. The three of them were from Lady Reading Hospital, Peshawar. So congratulations to all of them. Now, I request Professor General Suhail Aziz to come on the podium for his presidential speech. Professor Suhail Aziz.
Bismillahirrahmanirrahim. Assalamu alaikum. First of all, thank you to all the worthy honorable members for giving this opportunity to be the president of the society. It's a great privilege, and there's a presence of some wonderful, amazing people who've held this position, and I can see a lot of future presidents sitting here. I first of all would like to congratulate the course directors for holding such a wonderful Pakistan Live, and it's Alhamdulillah becoming such a benchmark of a meeting all over the country that other societies are following suit. We have tried to make sure that we don't try and overspend on this and be as economical as possible, but spend the most amount of effort and time on audiovisual, because all of this meeting is about audiovisual. I'd like to thank not only the course directors, but as this society has grown and Park Live has grown, the Orbit has grown with us. It's been our partner for quite some time, and we've had some very heated discussions on different aspects of it, especially the audiovisual. And as have we grown, so have they. And so I think this is a symbiosis sort of a situation. There were some wonderful cases, wonderful prizes, but I hope this doesn't give the message that if you have more complications, you'll get more prizes. Please think of the patients. So, you know, don't make more effort to get the first prizes. I can see some future potential winners sitting here. I would like all the young participants to be more involved. I hope we put so much focus on Pakistan Live that which is a really amazing meeting, but I really wonder whether this is enough to meet the educational requirements of our members. There's so much happening, and there's so much learning which needs to be done that once a year sort of a meeting becomes a real challenge. We have taken out the fellows course from Pakistan Live, and we've also taken out the nurses and the cath lab techs out of this meeting. And this was basically because not only did it add extra cost, we could not bring the techs from all over the country for this meeting, and the nurses and the fellows, and they were just impossible in terms of finances to bring them and accommodate them. And the worst thing was that you had to run a parallel course, so all the members sitting here our job is basically to teach our members how to do these complex cases and how to learn from them. But if half of them were out there giving lectures and giving courses which was of course very useful, it just they would not get that experience. So we tried to reduce the number of halls, but yet we could not reduce less than 2. And so what our plan now is that the fellows courses will be done in each big center every couple of months, and the faculty will go to every city and they will hold fellows course where they will go over the different lectures and different aspects of learning and even workshops, and have cath lab techs and nurses coming in from the regional area to that particular center. And we switch gradually every few months from one to the other, and so that will be dedicated to the local residents and the techs, so they would learn from that. We are always very open to suggestion, and if anybody has any issue, we dare to be as forthcoming as possible. You'd be amazed at the amount of activity which the council has to do, which nobody seems to realize what needs to be done. We had to almost get registered to the Stock Exchange Commission of Pakistan, and this was because the journal had to be registered with Higher Education Commission, and their basic requirement is that you had to be registered with SECP. And once you do that, all the council would be labeled, this thing will be labeled as a company, and all the members would have to become like directors, and they would have to give their assets declarations, and you had to give taxation every 15th of the month. You had to give tax for this, and so then we got in touch with the Higher Education Commission, and it was quite a multiple interactions, and we then unfortunately we had to use very stern language that we are a non-profit organization. What is this clause? They said, no, this is a rule now. I said, who made this rule? This is certainly not a Asmani harf. We are a non-profit organization. Make us understand what is the link between Stock Exchange Commission and a non-profit educational organization. And so there was a lot of resistance, and then we actually said that if you can't make us understand, I can't find the linkage, we'll ask a court to help us explain this. And so they actually, they removed this clause, and so all the medical journals which are being held, almost quite a dozen, they all got enrolled, and so did our journal get access to being registered with the HECP. So a lot of things have happened, and when we had to come for this Marriott as a choice, the PSL was going on, so we were used to the Serena, which was in fact cheaper than this. This is a bit smaller, and this is more expensive, and there was a lot of hue and cry by the industry that there's so many other meetings going on that we will be giving you less funding this year. But alhamdulillah, we've managed, and we will look forward to further interaction. And a word about the society. This society has probably the most responsibilities than any other medical society. Like, we have to give report to the Supreme Court that every one of you is registered as an accredited operator. And there was a lot of questionnaires, and some of the operators actually tried to hoodwink us also, just to see how effective we were. But alhamdulillah, we've done almost more than 800 of people have been accredited, and which has to be renewed. And there's a lot of hue and cry on the amount of money, which is 10,000 for 2 years. That is, but it has to be renewed. This is the by order of the Supreme Court. It's not with us. We try and soften it as much as possible for you people. But alhamdulillah, nobody has ever complained that there's been any irregularity or some favoritism, and it's a very transparent way of doing things. And now what we've done is that we have members, and anybody who wants to now become a member who can only be if he's an accredited operator. So some of the new people who've actually asked to be members, some of the members have actually they are not members as yet, but they've asked us to register them as accredited operators. So once you become an operator, you just have to complete the 5 years, which is the bylaws of the society, and then give a nominal fees of 10,000, I think 10,000, which makes you a member, and you become a member. So if you have any issue, please contact any one of us. We're here to look after your interest, and it's a big privilege to interact with all of you, and we look forward to the next Pakistan Live. And there's some complaints by the course director, not a complaint, just an observation that we as a nation are more relaxed, and Bashir Saab and the other wonderful members have been chasing the speakers and the panelists and so on and so forth. And there was even question of, let's ban this from happening. But I think we can't be so stern in this sea of what is happening around us. We are not a very law-abiding nation, unfortunately. I hope nobody objects to what I just said. But so we should take ownership. It's a big, proud moment to be, on the panel of these things, and we should, be aware. And people have been reminded, and yet some of us could not make it. It's just the way it is. We must try, and that's about all. So hope to see you soon. And another word of, I think it's worth mentioning that people do not get registered till the very last moment, and everybody would start ringing up a day before, mera kamra nahi hua, mera ye nahi hua, mera wo nahi hua. So So please, we're all been through this every time now, and lots of time the companies, the organizations and the societies and those meetings, they look after your rooms and all, but you must remind people, and you're all big people, if there's somebody who has issues, we can of course help you, but by and large, we all have influence on our different sponsors, and so remind them for a room early, because then when you're late, it becomes a real problem. And so with that, I thank you all and need your blessings, and we are all here to look after you and have safe journey back home, and have a great year, and inshallah we see you next year in Lahore, and the dates have been announced, and that's 9 to 12 April. I hope in Pakistan something always happens to make it, but that's Allah's blessings. We've tried to make sure that we don't have any overlap with any other conference, so that maximum number of people can, from overseas can come, especially the big operators, they can come to us. Thank you very much. Pakistan Zindabad, PSIC Pandabad.
Thank you very much, General Suhail, for your thoughtful insights. Now I would request Dr. Bashir, because Tahir Sagir is not around, to say vote of thanks.
Thank you. Dr. Tahir Sagir had to leave for the flight, so he asked me to give the vote of thanks. So I think I would start with thanking all of you for being here, and then obviously the outgoing council, without whose support this would not have been possible, all the directors and associate directors and the people who have been working behind the scenes. I think they are the most to be thanked. And I think after them, the most important is all our industry partners. Without their support, obviously this would not have been possible. You are seeing the logos and the names over there. On the left side, you're seeing those are all platinum partners who have contributed significantly. Medtronic, Boston Scientific, 4S, Ferrosons, Microport, Hilton, and Wilson, and Getz, Formivo, Shunmei, Genix, Tabros, and Brosmed, and Nabi Qasim. So they have very generously supported us. And despite the fact, you see there's nothing inside the hall, everything is outside, and other companies on the right side have also supported us, and I think without their support this would not have been possible. And on behalf of the society and obviously the course directors and the council, I'm grateful to them. And I think a big hand to them for this help. And finally, I think Orbits has been partner with us for a long time, and again we criticize them whenever there is a problem, but I think I've been kind of very upset off and on with them also, but I think overall we see that the quality of the conference and the transmissions is improving year by year. There is still some glitches which we still are working with them to improve that. But I think overall they have done remarkably well, and I'm really grateful for that. We have been started working with them like months ago, and especially with transmissions, again they have to really coordinate with international and the local, go there, test runs, and everything is being done before the meeting also, but at the last moment still things can come up. But a big hand to Orbits Wes and his team. Thank you so much, all those who are sitting here. I can't name everyone, but I think you people have been on your toes and done a great job. Thank you so much. And I think I would also like to thank the media people who have been here. Shine Siddiqui has been here covering our meeting, and she is making a small documentary. At the end, she would like that whoever is here, just few seconds message regarding the conference. If you can give it, we'll be making a documentary and using it later on. And again, I think Dr. Suhail has mentioned about the next year's Pakistan Live, April 9 to 12. So please put in your calendars and remember that too. And finally, I think thanks to all the international faculty Without their help and support, obviously, coming and their participation really improves the integrity and overall quality of the conference, and especially those who just came here for even a day or two. Dr. Omar Goktekan just came here for one day live case, and then he went back the next day and did the live case from Turkey. He has been a great friend, and we really appreciate his help and efforts as always. Our Chinese friends were here, and our own colleagues from Pakistan, Dr. Bilal Murad, Dr. Bilal Iqbal, Farooq Jalisi, Najib Azam, Wasif Qureshi. I think I'm not sure if I'm forgetting any, but all those international faculty were very helpful. I think we learn a lot from them, and we really thank them for being here, and obviously all of you. I see Vakar Bhatti sitting here also. He has been also from media and great support for our meeting and overall for the society. Thank you for being here. So I think with that, say goodbye to everyone till we see you next year, inshallah, in Lahore. Thank you once again. Please get together here for a group photo, and then please do have few seconds of recording your comments about the meeting to Shaheen Siddiqui. She's standing here.
लेके भागो और उसको पूछो
कैमरा बुला दें
मैंने कहा सब आप हैं इकट्ठे
बिल्कुल यार इतनी खुशी
हेलो हेलो यहाँ सेट कर दें यहाँ यहाँ मैसेज रिकॉर्ड कर दें
Easier for me also. Multan से जाने से लेकर I can easily drive. भाई the other lane. इसमें आवाज रिकॉर्ड हो जाएगी. ऐसे जाएंगे. ये रख.
मेरे भाई ब्लास्ट हो जाएगा जब आप फेस की लाइट उठाएंगे ब्लास्ट हो जाएगा कोई लोग नहीं कैमरे को नहीं यार मुझे इसका फ्रेम बनाएंगे क्या ब्लास्ट हो रहा है मुझे बताएं क्या ब्लास्ट हो रहा है सीधा सीधा ऐसे करके ऐसे खड़ा करूं बंदे को